Test, test. Hello.
Testing, testing. Hello, hello. Is it coming through your computer? Testing, testing.
Yes, I think so. Thanks, Jill. You're front and center.
Technological challenge for the morning.
Was that strategic on Deb's part? That's
probably a good idea.
Said turn it to green. Green, the other color.
it's this side.
Oh, okay. Yeah.
To go up.
See,
You can actually hear it.
I totally can hear it. I'll be muting my computer, but now that I've tested
Green, the other color.
it. You little troublemakers, you guys are gonna have some fun. All right. All right, everybody else on green? All right, and you can turn them back off after we've done roll call. All right, take us away, Matt.
Oh, that's me now. That's
Yeah.
right. Should we have like a guest president and have Tony come up and do it? Would that be okay? Or is that frowned upon now that he's staff?
Right.
You remember those
Yes,
meetings,
Chair.
right? That was fun. All right. Well, good morning, everybody. Welcome to the Saving Clear conference room for the Board of Health meeting. Today is March 20th, 2019. Should we do roll call?
We can. You can also introduce your new member if you'd like to do that before roll call.
That'd be terrific.
Okay,
I was
let's
going to
do
do it
that.
after, but I like your plan better.
Only because that way when people hear the name, they'll go, who is that, right?
That is a great idea. So we have a new board member. Sir, would you mind introducing yourself, please?
Sure. Tom Butts. I'm a Thornton resident, and I've worked for the last 34 years in local public health at Tri-County Health, Elbert County Public Health and Human Services, and Larimer County Public Health and Environment. Everybody uses a different name, I guess. And I'm happy to be serving.
Well, welcome.
Yes.
I think most of us are here, so you'll have an opportunity to, I don't know if we've strategically put you in between the two MDs.
I kept him away because these two wanted to sit together.
Oh, did
And
they?
yeah, so I said put him on the other side of the
So Deb separated you already. That's fantastic.
Little
That is
bit.
great.
Are well-mannered.
That's excellent. Okay, so I've called the roll. Say this is right here.
Nice. You're high.
Jill used to sit next to me in the board meetings, and she would tell me, like when I was actually doing a session, which was very helpful. Okay, I'd like to seek approval of the minutes as drafted, unless there are any significant modifications. Anybody have any modifications they wanted to point out, other than syntaxy, grammatical? No, great. Then seeking a motion to approve the minutes, please.
So moved.
Second.
Thank you. A motion and a second. All in favor, say aye.
Aye.
Aye. All opposed, same sign. Hearing none, the minutes pass. Thank you all very much. Is there by chance, Deb? So let's all be patient with Deb. She's running solo today. She does not have administrative support here. Is there any public comment for items that are not on the agenda?
No, but I will.
We'll do it when I'm ready. This one, she is so. Just kidding.
Matt's
We
also
also need to do
playing
a
solo.
roll call. This is my second meeting. You weren't here for the first one, so just know that it's going to be a lot of fun.
Performance.
Well, she threw me off because I wanted to. Yeah. Okay. Thanks.
Jill, you got to get a hold.
All right, I'm going to call the roll.
Okay.
Take a breath.
All right.
All right. So Evelyn is excused. She's
I have-
out
I
of
have
state
it.
with
Thank you.
travel. Butts.
Here.
Ingalls.
Here.
Estacio.
Here.
Hammond.
Here.
Estula.
Here.
Turk.
Here.
Vanaken.
Here.
Thank you. And
No,
I
thank
don't
you.
believe anyone signed up. Just to confirm, folks in the audience, is there anyone that wanted to offer public comment for matters that are not on the agenda? You are good, sir.
Fantastic. Who's not present? Sorry.
Evelyn.
Evelyn. Okay. Terrific. All righty. Are we ready? So exciting. All right. So first up, as always, sorry. Are there any board comments regarding matters that are not on the agenda? Hearing none. We will launch into our first rulemaking hearing. So as a reminder, oral testimony is permitted, but it will be limited to the scope of the rulemaking hearing. Written testimony is always encouraged, and oral testimony will be received only to the extent the board finds it necessary. That was Deb's phone, not mine, for the record. And we would limit you to 3 minutes or less, please, if anybody chooses to do so. So our first document is 5 CCR 1006-2 regarding the medical use of marijuana. If staff could please step forward. and then introduce yourselves and proceed. That would be terrific.
We're not getting the green light.
They're probably not turned on
Yeah,
the back.
turn it on in the back. It goes on to off. There you go.
Awesome.
There you go. Thank you, guys.
And then to
Got
Greg.
it.
Thank you so much.
Skills. All right. Mr. President, members of the board, good morning. It's a pleasure to be here. I'm Tony Capello, Division Director for Disease Control and Environmental Epidemiology.
And Daniel Vigil, manager of the Medical Marijuana Research Grant Program.
Great. And before I hand it over to Daniel, I just wanted to express the satisfaction I've had with the team and the ability to put this together. I think we've come to a pretty good conclusion given some of the restraints we've had, or just the ability to maneuver around the sunset rule, the executive order, and then, of course, taking into consideration the feedback from the board. Very fun process, interesting process, but just wanted to give that shout out that the team, I think, has come to a pretty good and reasonable conclusion. I'm going to hand it over to Dr. Vigil, and he's going to move it forward. Thank you very much.
Thank you. Good morning, Mr. Chairman, members of the board. The department proposes amendments to 5 CCR 1006-2, medical use of marijuana, Regulation 6, which outlines the petition process to add a debilitating medical condition for which patients can be approved for a medical marijuana card. The driving factor for this proposal was feedback via sunset review and executive order that the current petition process is too restrictive because it requires cannabis research that is extremely difficult to conduct. It will take time to build the body of evidence. So we presented proposed amendments at the January request for rulemaking. And based on the board's feedback, we have revised this proposal. The revisions are highlighted in the packet. So the proposal before you modifies the additional pathway that we proposed in January by allowing the department and the board to consider published peer-reviewed case reports as part of a petition to add a debilitating medical condition. At the January request for rulemaking, the department discussed an important theme of stakeholder feedback, that the rule should allow patients and physicians to share their lived experience by documenting it in a letter and submitting it as part of a petition. The board agreed that patient experience is relevant and important, but noted that it does not constitute scientific evidence. The current proposal allows for patient experience to be included if the scientific and medical evidence is sufficient and the board sets the matter for a rulemaking hearing. We believe this strikes an appropriate balance. Excuse me. Case reports don't face the same research barriers that that randomized trials and observational studies on cannabis do, but being peer-reviewed and approved for publication requires greater scientific rigor than anecdotal evidence. We also want to touch on 2 additional areas where we received board feedback. We want to make it clear that submitting a petition with this alternate pathway does not guarantee approval of the petition. We have updated language in the proposed rule, clarifying that the department will evaluate the available evidence and determine whether a petition should be advanced to the board for consideration. Randomized controlled trials and well-designed observational studies will continue to be the primary pathway. This new alternate pathway, for this pathway, the key factors of analysis in addition to case reports will be evidence of biological plausibility, relative safety, and that current treatment options are unsatisfactory. A petition may be denied or may be advanced to the board for your consideration. Second, we have added language to the proposed rule that states the department, as part of a review of a petition, will conduct an analysis of whether and how the department could monitor for adverse effects of medical marijuana use for the proposed medical condition. And finally, this updated proposal has been distributed for stakeholder feedback, and no additional feedback related to this proposal was received during the allotted time period. So with that, we'll be happy to take any questions.
I would also, pardon me, I should have deferred. So every time we have a hearing come before us for a decision, for example, for document 4, Mr. Butts, we'll ask for a hearing chair, and then one of the board members will volunteer to chair that. Mr. Turk kindly did that for this item, and so I should have deferred to Mr. Turk to run this actual item. I made that mistake on purpose to show you how that works. And it's my pleasure. So, Mr. Turk, the floor is yours.
Don't volunteer, you get your arm bent all the way back here.
That's right.
Okay. Now I got to figure out where I'm supposed to step in, so give me a second. Okay, thank you, staff. Chairman. Do we have any questions for staff from the board? Dr. Pastula.
Hi, Dan Pastula. So thanks so much for listening to our comments in January and adjusting things. I really appreciate that. I do and generally worry about kind of that lowering the quality of evidence, because no other drug for medical purposes we allow case reports. The FDA allows case reports, but I am sensitive to the fact there are a lot of federal barriers to research this, like you do other drugs. So I definitely appreciated the keeping that peer-reviewed thing in there in terms of case reports. One question I had was, is there a working definition of peer-reviewed, published peer-reviewed? The reason I bring that up is because I and probably some other members of the board occasionally get emails unsolicited from various parts of the world saying, hey, you can publish this if you pay us like $1,000 and it's, quote, peer-reviewed. No, I've never done that either. I've gotten emails for that, but meaning, like, is there an operational definition in there? Like, does it need to be like indexed in like PubMed, for instance, or were there?
So yes, that is a challenge. Thank you for the question. There is a clarification that I believe about what peer-reviewed means. Sorry.
I think it was published in Medline or something like that. That was written on. Yeah.
Yes. Sorry, finding it at the moment, but yes.
Next in Medline?
Oh, perfect. Sorry.
Okay.
There you go.
We're good.
Question answered.
Scopus, Web of Science, or Directory of Open Access Journals, right at the beginning. That's why I missed it.
I missed it too.
Well, it's hard.
Who has some duct tape? Just kidding.
I know. I do have to.
Yeah. Any other questions? Dr. Estacio.
Yeah, just to follow that in terms of level of evidence, I totally understand that part and the pressures that you're under, but I appreciate that you guys are going to do a thorough vetting of petitions, because to follow up on Dr. Pastula's is I'm even more uncomfortable with the biological plausibility argument in regard to that, in addition to patient experience. But I imagine you put that in, but you'd vet it and look at the relationship of, because oftentimes biological plausibility leads to from preclinical to clinical trials and first step into humans in terms of doing that. And so I just was wondering how you would handle that kind of petition when somebody submits a petition based on biological plausibility and potentially anecdotal patient experience of just those case studies associated with that condition and the utilization of marijuana.
Right. Yes. Thank you for the question, because that's definitely important. Is that process of really vetting the evidence. Excuse me. And honestly, there becomes some point where there's a bit of subjectivity about the quality of the reporting in the case reports and the quality of the suggestive biologic evidence. In addition, of course, we are looking at the relative safety and thank you, and other current treatment options. And so, it's really just a matter of whether the overall evidence really supports a conclusion that it is more likely than not that cannabis would provide medical benefit and that benefit would exceed the potential risks, which, depending on the patient population, those risks are maybe greater and require a stronger evidence of potential benefit.
So just to add to that, so potentially, if there's no in-human publications or in-human studies studying the effect of marijuana on a condition, you could potentially, a petitioner could potentially bring forth an indication to be reviewed just based on what they might see in animal studies and things like that. And then that would be the tough part, is because, you go from, a far off example is like mother's chicken soup cures colds. I mean, it kind of, it's not, maybe not that quite extreme, but since there's no human studies associated with it, I'm just saying that would be a tough evaluation. And then would you see an example? Is there an example that you could think of that might lead to that level, that it ends up in front of us to seek approval for an indication? I know it's a tough one. I can't think of one myself.
Yeah.
So.
Yeah, I appreciate that. And honestly, some of the examples that come to mind are conditions that are already on the list.
Right.
I can't think of others offhand. One thing that I think is a really important sort of pivot point is again the relative safety and the potential for harm in the particular population that is the subject of a petition. So, a generally healthy adult population, the potential evidence of benefit could be lower to go ahead and advance the petition for board consideration, where particularly in children, for example, we know the amount of potential risk, and it would really take pretty compelling evidence to support a petition.
Okay. Yeah, because I could see a scenario would happen where people kind of cite something that's associated with not published data, maybe not preclinical or not in humans, and take that opening, and you might get inundated with a bunch of potential proposals and petitions. So
Right.
that was, I was trying to find a scenario where that biological plausibility, it would make a case for indication. Is the only thing.
Well, and on its own, it would not be sufficient. There have to be the case reports as well.
Yeah,
And the other-
but I think that was one of the
Yes.
conditions that was listed on here, I think.
Sorry, what?
I
Biological?
think that's, biological plausibility.
Yes, it's a all and,
Yeah,
not
yeah.
not an either or. Yes.
Okay.
Dr. Pastula.
They're just bouncing.
Boy, I didn't want to sit you.
So how have you figured out how to evaluate the kind of standardization of marijuana products? So for medical marijuana, there are over 100 in marijuana. There's over 100 phytocannabinoids and over 200 terpenoids. In different formulations, wherever you get it, will have different levels of things. So a case report might have using one formulation that's very standardized, which may be very different from the thing you might get kind of down the street at a dispensary. And, unlike, so for instance, the new approved product, the Epidiolex for seizures, which is kind of pharmaceutical grade CBD, you're going to have a lot of differing values of these compounds. How will you address that kind of going through and approving this, especially when the literature might be coming from different states and with different formulations and different compounds.
Right, right. That's a great point. And our initial drafts actually included language about the possibility of limiting an approval to, say, CBD or to certain formulations. Unfortunately, we recognized that we don't have the power to do that, that if something is approved, it's simply approved for the condition, and there are no specifications about the formulations. So it certainly is a challenge. And as far as this petition review process, if it was clear that that some common formulations that are available could potentially be more harmful than others, then that would be the sort of the baseline that would be considered for the risks. I don't know if that's clear.
Yeah, I guess my concern is, my main thing is I don't want to do any harm, for these things. And so I just, when these petitions do, if and when these petitions do come up, it's just clear that these compounds may be very different from each other, that they're all labeled medical marijuana, but they could be absolutely different compounds and combinations of compounds, some of which we don't really know what they do, especially when you get in some like the terpenoids and various other things, and whether they have drug interactions or all those things. So I think from my end, that's one of my concerns.
That's great. And I'll jump in there just real quick on that. I think it's something we discussed a little bit last time, is that, again, the whole purpose of this is to bring it in front of our scientific experts to take a review and take a look. And then, of course, with this evidence and these other pathways, we're going to weigh that and say, yeah, do we see harm? Do we see evidence of benefit? And if we do see harm, that's going to be our duty to report that to the board and say, yeah, maybe in this formulation, we're seeing this, that we're not seeing any more harm. But however, for example, we're seeing in children 7 to 10 a detrimental effect. And so that's what we would want to bring into that process is that our experts will be reviewing that, taking all that data so that we can present the board with as much information as we possibly can, given what was given to us. And then I think we talked and touched a little bit about that before, is that we want to push it through a process like this, just given the fact that we do have scientific review, both at the department and both at the board. Because we do know that currently a lot of that is being passed straight to the legislative process, where we're not seeing that. And so, yeah, I think that's where we get back to this balance of trying to make sure that we're getting as much scientific review on this to make sure that the board, if something does come to the board, that they're going to be educated on that decision. So yeah, hopefully that addresses it a little bit more. Thank you, Dr. Pastua.
Ms. Heyman.
On that subject, how do you see this affecting the things that are being pushed right to the legislative process?
Well, unfortunately, we don't believe that this can have much impact on the legislative process, other than the possibility that some in the public or in the legislature might recognize that with an alternate pathway, it may be worth taking this path instead of going straight to the legislature.
Yeah, this is a process question than anything on the medical side. The expectation is with this rule change that there could be as many as 9 or 10 new petitions. It's going to take, according to the report here, considerable staff time to process these, and it doesn't look like there is sufficient staff to get them processed timely. What plan is there to make sure that everything gets processed appropriately? What additional resources you're going to need? How are those resources going to be funded?
Do you want me to speak to that one? So I do think it's important to know that the 9 or 10 that we put in the regulatory analysis for the board's consideration was an assumption. It was based on what other states have put on the books, and we sort of started there. To Dr. Estasio's point, they could come in tomorrow with 20 new petitions with 1 page of evidence 400 pages of evidence. You just don't know. And then they have 180 days to get it through the process. And the way we have that set up is that the department gets 90, and then it comes to the board for the second 90 if they want to pass it forward. And that way your adoption date gets in under that 180 days. So the piece about the analysis, it is something that we've talked about because we want to make sure that we're not setting ourselves up for failure. If the quality of the evidence coming in isn't there, the department has the opportunity to say, denied, you haven't shown us the case. We were careful with that language there because we wanted the community to know, we're not going to go out and prove your case for you. You are the petitioner. But we did want them to know that the department was going to make sure that the study of harm would be exhausted to the extent that our scientific experts could do so. Then, after all of that, excuse me, you have the backup plan, which is all of this work is funded out of the Medical Marijuana Cash Fund. That fund can be increased. It is set by the board. So if it is the will of the stakeholder group for us to entertain those petitions, then we can increase the fee to get the dollars to support the staff to do the work. But you're right, there's a lag there, right? We're going to have a problem before we can satisfy it with a fee increase. And we also have TABOR issues and all of those great things that we have to be considerate of.
But what is the repercussion of not meeting the 180-day requirement right now?
So repercussion would be that we have violated the Constitution. They're going to go straight to judicial review of the department and the board's action. That's the repercussion. And Jen, do you have anything to add on that? I'm assuming that's it. Sorry, that was just so slam dunk. I felt like I could. So.
Any other questions for staff? Okay.
Good luck.
We're not done yet.
Oh,
we have
Ms. Hammond has one more question.
Following in that train of thought, I realized that the staff was taxed with putting this together because of an executive order. And what is the timeline on that executive order that this must be completed by?
Would you like me to speak to that part too, or do you want to take that one, Daniel?
Oh, I can speak to it.
So it's only in part through the executive order issued by Governor Hickenlooper. And I think that's important for the board to remember that there was also a sunset review of the medical marijuana registry that came out of the Department of Regulatory Agencies that really recommended that the department take a review. So there are multiple motivations for this. We have a sunset review saying your process is unachievable. And when we have SMART goals and we ask for folks to have things that are achievable, our rule doesn't do that. So is that for all the reasons, saying, ask the question, ponder. It's not that the recommendation went so far as to say it should be modified. I think the recommendation was it should be studied. There's a difference there. The second piece is the executive order. So the executive order was more about the department, if you need to look at your rules so that if by September of 2019 a petition was received for autism spectrum disorder, have everything lined up. So our timing here is that you're entertaining it now so that if we were to receive a petition this summer, which is when the department study would conclude as to whether or not using medical marijuana to treat symptoms associated with ASD is appropriate, we would be ready so that we could timely hit that piece of the executive order. That said, it very well could be mooted out. The legislation before the General Assembly is already in the second house, anticipated to pass. So we already have that in your rule. If it's already on the books, we don't need to entertain putting it on the books twice. So that sort of moots out some of that piece. Does that make sense?
Yes, thank you.
Okay. All right, we're going to go ahead and move to public comment. So we've got Ms. Weaver Hayes up first. And I am going to remind folks, please come up, introduce yourself. Let us know if you're representing some agency, and we're going to limit testimony to about 3 minutes.
I'll get your timer.
Thank you. I'll do my best. So my name's Anna Weaver Hayes. I'm the executive director of the Colorado Psychiatric Society and the Colorado Child and Adolescent Psychiatric Society. And I'm testifying today on behalf of Children's Hospital Colorado, the American Academy of Pediatrics, the Colorado Academy of Family Physicians, Denver Health, the American College of Emergency Physicians, Colorado chapter, the Colorado Society of Osteopathic Medicine, Colorado Psychiatric Society, and the Child and Adolescent Psychiatric Society. And I can write that down if needed on some sheet. Okay, great. So I'm here just to express our general support of the proposed changes, but also to highlight a few of the changes we especially specifically support. So the first one is C, sections 1 through 3. We appreciate this section of the proposed rule that outlines clearly and robustly the medical and scientific documentation required for a petition. And we support that greater weight is given to peer review documentation. The next section is D5. And we support this provision because there could be an instance where the petitioner must specify a particular age group for medical marijuana use to treat a debilitating condition, and doing so offers some additional protections for children and youth. Moreover, to the extent possible, we recommend requiring the petitioner to include the approximate length of time for which the medical marijuana is needed for that condition, as well as, if possible, the potency and product type, especially for children. We also support D3A. This is important because it builds some accountability into the process. D6, which streamlines and simplifies the steps. D7, to monitor adverse effects of medical marijuana. Section F is very important to us, which is authorizing rulemaking to remove a condition if there is robust scientific evidence that there's harm. And so the healthcare providers and institutions we represent treat people with these debilitating conditions every day. So we appreciate the struggles, the frustrations of the families, of those living with the conditions or caring for people with them. But that said, we think it's vital for the health of Coloradans to ensure that these alternative treatment processes and models have scientific evidence and are backed by that, especially when they're categorized as medical interventions and require a certificate from a physician. We further believe that while the proposed changes are satisfactory, one additional change merits strong consideration, namely that the board should have the ability to amend a petition to require a pediatrician, child and adolescent psychiatrist, or primary care provider to be actively involved in the clinical care so that we can monitor the impact, whether harm or benefit of the condition. Now, I assume. Thank you. I have one more quick comment. That could be inserted into D5, and we just think that's a key provision that would help understand more comprehensively the patient's medical history with regard to that specific condition. It would help physicians thoroughly assess the potential benefits of medical marijuana use for treatment of that condition. And with that, I'll just say thank you for allowing us to comment, and I'll do my best to take questions if there are some. We were planning on having a physician here, and last minute she couldn't make it. So,
have you provided the additional verbiage or feedback directly to staff until or before now?
Do you want me to speak to that?
Please.
So our staff have reached out to the groups that were identified here throughout the process. Unfortunately, they didn't meet the timeline for timely testimony. I received it last night. I let the constituents know that it was untimely and therefore the board couldn't admit it, but did say that the board accepts oral testimony. And appreciate that you're pinch hitting.
Ms. Hammond?
Could you repeat that your suggestion was to add a psychiatrist and a pediatric?
Sure. And I'm happy to leave this little sheet with all my notes on it to pass around. Yes, so we think the board should have the ability to amend a petition to require a pediatrician, a child and adolescent psychiatrist, or a primary care provider to be actively involved in the care of a child.
Thank you very much.
And that is what we're most concerned about, is youth.
Yeah.
So, this is more of a process question. Can we bring up and ask staff to come up? Because to me, that sounds fairly reasonable that
Staff will come back up.
from that. So I kind of want to ask staff maybe for that, unless anyone else has any questions, but good point.
Yeah, I think we can have staff come up after everybody has come up. Yep. Thank you.
Thank you so much.
We've got Miss Kelly, followed by Art Way, just to be in the batter's box.
On deck.
On deck, thank you. It's been a long time since I've.
Good morning, board. My name is Christy Kelly, and I'm the Executive Director of Marijuana Industry Group, which is Colorado's oldest, largest, and most diverse group of licensed and legal businesses in the state of Colorado. We have about, a little bit over 500 licensed businesses that we represent, the vast majority of which possess both medical and retail licenses. I'm also a former medical business owner myself and a founding trustee of a nonprofit that advocates and provides resources for parents of children who have debilitating conditions that are able to be helped by cannabis treatments. I'm also the sister of a very strong woman who is currently fighting breast cancer and who has been helped by medical cannabis treatments. What I am not is a doctor, so I just wanted to disclose that I don't even play one on TV. The combined effort and effect of both the medical and retail programs being constitutionally accessible in the state of Colorado has had the impact of shrinking the medical patient population from at its peak over 100, maybe 120,000 patients down to where we are now in the 80,000 range. And that is because more adults are able through retail marijuana to self-medicate, whereas previously under a medical regimen, they were required to go through the CDPHE process to get a designation. And so there are fewer people that have treatable conditions in the medical market that can exercise those retail options. And what that means is that the reason that a patient chooses to stay in the medical system is a function of either personal choice or necessity, because they have other things in their lives, whether it is an insurance requirement, professional demands, subsidies that they receive from third parties or government entities that require that they de facto preserve their medical status as a patient in Colorado. So the chance of abuse of this petition process, in my opinion, is fairly minimal in recognition of the fact that the large number of people who are able to already exercise this option independent of medical board consent are already doing that. And what we have are the people who are desperately in need of some sort of a relief because they rely on these other functions and structures and support systems that typically are the ones that come to you and come forward to this board. You may have, for some of you, and I recognize some of your faces, case in point, veterans, parents of the extremely sick, and the like. And so their need to come forward to this board is driven by many things. One of which is a real desire to work inside of the structures that the system is asking them to work inside of. The status quo for expanding the medical impacts has proven to be very challenging for these folks. And as restrictions that you are also regulatorily required to adhere to have made it almost impossible to add a single debilitating condition since Colorado legalized medical marijuana in 2000. So consequently, we have seen other states, and it was referenced here, and other countries be able to be much more flexible to the evolving needs of cannabis patients in the medical side. And I believe that this board has recognized that this similar privilege has not been extended to this board because of the regulatory constraints. Further, this impasse has created the need to push through solutions, as Ms. Hammond indicated earlier, through the legislative process, because the current parameters are just a little bit too limiting to move forward. If I may, just my final closing comments. The concern about the general harm is mitigated by the patient's history and would not necessarily impact the ability for this board to exercise their very serious responsibility to preserve and protect and mitigate harm. These requests are coming from patients who really need that help and really need a pathway forward that is legal and legitimate. So thank you. Our organization is wholly supportive of anything we can do here to expand the petition process for approved medical conditions. Thanks.
Thank you. Any questions for Ms. Kelly? Thank you very much for your testimony.
Thank you.
Art Way? No? Going once, going twice. Ms. Weber? Ms. Weber?
By any chance, are there folks that signed up for the wrong document?
Well, no, they asked me to sign up for them, but they were signing on.
Okay.
Okay,
Well,
thank you.
nonetheless, thank you. I appreciate you saying something.
All right. If we can have staff come back up real quick. Dr. Pastulo, I think you had a couple questions.
Yeah. So would that be feasible or reasonable to add what our first testimony said about kind of for kids requiring that their main pediatrician or primary care doc or child and adolescent psychiatrist be involved in those decisions where that we could amend a petition for that? Because I think part of the reasoning for that is basically so that they don't get approval, especially when you're involved with kids, where the risk of harm is potentially higher, that it's not just one doc that sees them one time that provides that, but someone who follows them longitudinally. So would that be feasible to add that?
I think, yeah, let's start with the legal side.
Sorry, just there's a lot of moving parts here, folks. So
yes.
The first piece is to know that this came to our attention pretty late in the game. And so I do want to acknowledge that the department's worked really hard on our stakeholder relationships. So I really want to be sensitive to that and would ask the board to be sensitive to that, because if we are doing a shift, and I'm not saying we are, but if you are doing a shift, it sort of harangues the entire process. And so that's the reason why we have those deadlines in place for folks for timely testimony, so that everyone has that opportunity to react. It gets posted on the website, etc. The second piece to this is that right now in the proposed rule, it gives the department authority to amend a petition by working with that petitioner, because perhaps as they're reviewing that science. So we listed up there a couple of examples of instances where maybe you want to tailor it by severity, or perhaps it does serve a certain population. Maybe there's a different response between gender, sex, etc., that we need to be sensitive to. So we purposely were quite vague when it came to the board. And that's the second piece. Procedurally, when you're considering, because we didn't think it was appropriate to bind you in a rule, but we just sort of gave you some suggestion language for what you would want to consider. Sorry, there's a slight delay when I'm moving things. So this is what we have. And the reason why we offered this to the board is, I'll remind folks of the January presentation. When we had the petition for PTSD, board members struggled a bit with the amount of latitude they had and were wondering, what is our standard? And this just gave you something where, of course, you could deviate from it, but it gave you a starting place for being able to have a rubric for your assessment. So it does nothing to limit your decision-making on a petition. So just from the legal vantage point, Jen, do you agree with that construction? And then I can kick it over to staff. Are you dead too? Oh, okay. All the steps, I know.
Okay. Yes, I agree with everything you said. I want to also note that, I mean, that issue, though it seems like a reasonable thing, it seems different than the petition process. I mean, I think as we discuss, it really gets into the relationship between the doctor and the patient and the bona fide patient relationship requirement, which is required and is separate and apart from whether or not a medical condition should be added as so that's my comment.
Yeah, those are fair points.
And as each petition comes to us, then we can have recommendations regarding potentially monitoring for that condition in order for that to move forward. And it's not in here, but it'd be associated with that specific indication for that utilization of marijuana for that condition. We could make that recommendation. For example, if the status is not strong enough, or we feel borderline, but we think it should move forward, we could recommend that there be some kind of monitoring for this condition, some data gathering to add to the literature or evidence to support that potential indication if it was borderline.
Do you want to take it or would you like me to?
You can.
Okay, sorry, we're on a roll here though. So yes, you absolutely can recommend that. The department will then need to consider its capacity to do so. And again, just going back to January, this is a registry. It is a piece of paper, and if everything looks copacetic on that piece of paper, they therefore get their card. And so to say, yes, you can have your condition listed, but only if you're agreeing to participate in our surveillance of your condition, that for me would require a lot of study, both from a capacity of personnel and FTE, as well as legal authority, given what the scope of the registry is. Okay, I want it full disclosure. You can make that recommendation. I just don't know if we could do anything with it. Okay.
I'll summarize a little bit on our side of it. So yes, definitely. I'll throw some program in there. I think with this process, this is kind of what we've alluded to, and I think both Dr. Pastula and Dr. Estacio are mentioning is we really want this to be a partnership on that. So what we're going to pull forward is just that, the information we have, and then it goes to the board to also review that with your scientific expertise to go, where are we seeing the harm and the benefit? So again, back to that point, is we're going to have that availability to do that. To Deborah's point on this too, is that, given the fact this is the first time we're hearing about it, it'd be very hard for us to give you a logical or accurate review of what this would entail, how it can entail. Again, back to cost of the department and how much time and FTE. So I think that would be very difficult at this time. But knowing that this does open up that partnership for the scientific review, both from the experts of the department and the board, I think that does can answer that question and have the ability to make that something that's comfortable for the board as we move through this process.
Thank you.
Any other questions for staff before we close the record? Seeing none, we're going to go ahead and close the public portion of this hearing. Thank you, staff. And we're going to go ahead and open it up to board deliberations. Comments, Dr. Pastula?
Yeah. So, I appreciate everyone's testimony today and as well as staff's work on this. I always worry about lowering the quality of evidence on things, especially if we're recommending it for medical purposes. But I also totally understand the barriers to research around marijuana, particularly at the federal level. So on one hand, I continue encouraging Colorado, as we've been doing, to try to lower those barriers for such quality research. And I think we have, with our funding of various studies on there. So, kind of given that, I'm inclined to support this, realizing that when individual conditions come, that I'm going to carefully or evaluate for risks of harms and benefits, and also the standardization of compounds, because I'm going to want fairly clear evidence that there's benefit more than harm. So kind of given that, I'm inclined to support this, given the changes that have been made.
Thank you. Ms. Hammond?
I agree with pretty much everything Dr. Pastula said. It's on, but how's that? But I'm quite conflicted between my concern for potential for harm and the lack of standardization. There's the two issues that really worry me. And I don't see that this really assists much in affecting the legislative process that's been happening regardless of what we do. So I'm concerned that the document doesn't call for a length of time of treatment. I think a 2-hour treatment for some things can be great, whereas are we looking at this for 5 years? And so I'm concerned about the amount of information submitted to the scientific group in terms of the time of treatment and the time necessary in the long term. So however, I see exactly what Dr. Pastula is saying, is that we're attempting to move through the public demands or the public requests and to try to do this in a scientific way. And I have great respect for our scientific council to look at all of these ahead of time and prevent some of it from coming to us that doesn't have enough scientific evidence. However, I'm very conflicted about the whole subject, so I'm eager to hear what the other members have to say.
Dr. Estasio.
Yeah, I agree with Dan. I support this proposal because I think we have a safety net, which is the staff, and you know I trust their ability to examine the petitions carefully, but at the same time allow things to in terms of potentially getting petitions through that may have some benefit, and it'll be up with each review. The nice thing is that as each petition comes through, we can look at it specifically and have our own recommendations. So this is not like a blanket statement, but it creates a process by which it could be reviewed. Doesn't guarantee that it moves forward, and that's what I'm comforted by, because I think there's enough concern on the board right now about letting things go through that might cause harm, that the vetting process, two vetting process through the staff and then through us, could hopefully safeguard against that or mitigate any potential risks.
And Ms. Hammond, I have the same concerns you have, and that's what gave me comfort, is the fact that by approving this doesn't automatically approve, that we'll have a chance to listen to each condition and the evidence there and then decide based on the evidence presented whether the benefits greatly outweigh the risks. So that gives me a little comfort to those things, but I absolutely agree with you. Those are the two things that are on my mind.
Yeah, Mr. Ingalls.
Well, I certainly recognize and appreciate the concerns from the medical side of this argument. I absolutely agree that the rule as it exists does not allow additional conditions to be added. I mean, it is impossibly high bar. So I'm absolutely in favor of implementing the change. And I am glad that there are some safeguards against just anything being added. But I'm thankful for the testimony from the industry that recognizes that we are in a condition where those who aren't forced to remain within the medical marijuana confines can simply walk in the door of the other door of the same facility, buy the same product at perhaps a slightly higher price point, and self-medicate without the benefit of having that relationship with a primary care physician. So being able to lower the bar a little bit, I think, is a great benefit to many of the people who must stay within the medical marijuana confines. So I'm very glad that we're going to make this change, or I hope though that we will make this change today.
Oh gosh, Mr. Van Auken. I feel like I'm left out. So my portion of deliberation is just a comment to staff that. You know, for the first few years I was on this board, it seemed like things were relatively cut and dry. It was more radon and dairy, which I'm super excited to hear about in just a little bit. Please. And parts per billion and, you know, udders and things. And now it's, and now it seems like we, the last few months have been sidled with, and staff, more importantly, has been sidled with, trying to thread some needle while rolling along in a roller coaster at Elitch Gardens. And I just want to commend your team, Tony, and you and your team, because this is, from my perspective, the best solution that we could have collectively come to that meets the needs, all the while being very adamant about listening to our trusted community partners, like the folks from the first testimony, and please know that your voice is very, very important to us. But so are our requirements as a board and the things that we have to, the rules that we have to, and procedures we have to play by. So I just wanted to thank the staff for doing such an admirable job.
Ms. Hammond.
I wanted to add also to my comments that I'm really impressed with the work the staff has put into this and the the scientific committee, because it's not an easy subject, and I know that you have worked with our stakeholders very carefully. So I just wanted to add that please. And I know that Colorado is being looked at across the country and across the world for how we handle these things. So please bear in mind to the public that we're looking at this very carefully for protecting our own citizens, but because Colorado is really being watched for what we're doing and setting a standard. So thank you for the time and effort you've put into this. And I think as a group, we can move forward would be my thought.
Any other board comments or deliberation? Going once, twice? Nope. Okay, thank you. So we'll close board deliberation at this point, and I will ask for a motion. Dr. Estacio.
I move to adopt the proposed 5cc R1006-2 along with the statement and basis and purpose specific statutory authority and regulatory analysis.
Do I hear a second?
I'll second.
Dr. Pistula. So we've got a motion and a second. I guess we just go to a vote now, right? Yeah. All in favor, say aye.
Aye.
All opposed, same sign. Hearing none, the motion passes. Thank you again to staff, and thank you for the public that came and took time out of your day to provide testimony. It was incredibly beneficial. So we thank you for taking part in the process.
Thank you all.
Do I get to take over the rest of the meeting now?
No. No, but Mr. Turk, outstanding job, especially with the poor introduction that I gave you. So thank you for doing as good a job as you did. All right, next up we have document 2. Our chair for what happened? Hi, Dr. Pistula. Our chair for document 2 is Dr. Pistula. I have the list. That's what I was looking for. And then Ms. Hammond, your document 3. See, I got in front of that one. So Dr. Pistula, I'll turn it over to you.
Yeah, hi. So just want to, so we're going to be discussing proposed amendments to 6 CCR 1010-4 Colorado Milk and Dairy Product Regulations. So confirm that the board has a quorum. We are at the Claire Sabin conference room, Sabin Claire conference room on March 20th at 10:58 p.m. And so, yeah, so we'll open with staff first, and then we'll have any public testimony. Has anyone signed up for?
No one has signed up.
Okay. So
wait till they find out we're infusing milk with marijuana. I'll fill this place up and make your day.
So we'll. So
that makes me very.
So, Seth, I will turn it over to you all.
Listen, it's going into beer, so if milk is not left behind, I'm sure.
My name is Kerry Rubel. I'm the Regulation Development and Enforcement Coordinator for the Division of Environmental Health and Sustainability.
And I'm Bradley Turpin, Milk and Corrections Program Coordinator with Division of Environmental Health and Sustainability.
Good morning, Mr. Chairman and members of the board. Brad and I are here today to request that the Board of Health adopt the proposed amendments to the Colorado Milk and Dairy Products Regulation. Every 2 years, Colorado's milk and dairy regulation is updated to incorporate the most recent version of FDA's Pasteurized Milk Ordinance, or PMO. The board last adopted these federal regulations in November of 2016. The PMO is the official document establishing the sanitation requirements that govern the nation's milk and dairy industry, and is formally revised every 2 years at the National Conference of Interstate Milk Shipments. The incorporation by reference of the 2017 PMO into Colorado's regulation maintains alignment with nationally accepted standards and sustains a significantly efficient rulemaking process. In October 2018, the division notified stakeholders to discuss the proposed changes to these regulations and requested their feedback. Consensus on the proposed revisions was achieved at both the state and national levels, and multiple stakeholder letters of support have been included in the rulemaking packet that we provided. Thank you for your consideration of our request. If there are questions or comments regarding the amendments to this regulation, Brad and I would be happy to address those now.
Yeah. Do board members have any questions?
I saw that. It's like, oh my God, I had to look it up. It's a whole industry. Other than that, I have no comments.
Do we have camels here in Colorado? Like on farms?
Yes.
We do, yeah. That farm's located in Ray, Colorado, almost on the Kansas border. Yeah.
And on a related subject, I've milked alpaca and llama.
Oh.
2 jokes in one.
Was that a joke? Or that might have just been a statement.
That was not a joke. I actually have done that.
Okay. So seeing no other board member questions, thank you for presenting. Do we have any public testimony? Would anyone like to sign up for it? Okay. So seeing none, then I will close the record and see if the board has any deliberations. I, for one, just want to thank you all for kind of updating our milk safety regulations, and very much appreciate the hard work you all have done. Given that, may I ask for a motion to approve 6 CCR 1010-4?
I move to adopt the proposed, just said the number.
Milk and dairy regulations, you don't have to know.
Milk and dairy regulations, along with the statement of basis and purpose, specific statutory authority, and regulatory analysis.
Can I ask for a second?
A second. Oh,
I think Dr. Stasio beat the punch there.
Okay.
So Dr. Stasio, and so all those in favor say aye.
Aye.
All those opposed, same sign. The motion carries, and thank you very much for your hard work on this.
Thank you.
Thank you very much. Dr. Pestula, thank you very much. Great job.
Thank you for letting me chair.
Through the whole thing. All right. Next up is document 3 regarding emergency preparedness and response. Staff is here and ready. Ms. Hammond, the floor is yours.
This is the most complicated of the morning, and so thank you for the opportunity. I'm confirming that we have a quorum, and I'm confirming that we are still at the Saban Cleary Conference Room, and I'm confirming that it's 2 minutes after or so after 11. And so welcome everybody for this hearing. We are going to look at the rulemaking hearing for amendments to 6 CCR 1009-5, Regulation 4, rules and regulations pertaining to preparations for a bioterrorist event, pandemic influenza, or an outbreak of a novel and highly fatal infectious disease or a biological toxin. That was the hardest part of this whole project. And we do have a sign-up sheet if anybody from the public would like to speak. And we'll just, in terms of rules, it'd be great if just one person could speak for a group. And do we have any conflicts of interest? No, and so we'll move right ahead to the staff presentation. Thank you.
Thank you. Thank you, Mr. President, Madam Vice President, members of the board. I'm Dane Matthew. I'm the Director of the Office of Emergency Preparedness and Response.
And I'm Julianne Berton. I'm also a member of the Office of Emergency Preparedness and Response.
As already mentioned, we are here today to propose the removal of Regulation 4. The regulation was last updated in 2007. The department and stakeholders agree that Regulation 4 imposes unnecessary and unenforceable requirements that do not improve the community's ability to respond to emergencies or duplicate other efforts. Colorado's 11 RETACs provide coordination, outreach, and educational roles, but they are not themselves response entities. Regulation 4 requires the RETACs to maintain up-to-date notification lists of pre-hospital care organizations, conduct operational notification tests twice a year, and provide advice to those organizations on creating plans. The RETACs as an entity would not normally perform these actions or provide notifications in the event of an emergency. Therefore, it is unnecessary and ineffective to impose these requirements upon them. Regulation 4 can be repealed without any impact on other community partners identified in the rule. Further, the department found that the structure to establish the department found that the structure established in other sections of the rule is sufficient to meet the community's needs, and thus it is unnecessary to substitute another local entity for the retax. The Office of Emergency Preparedness and Response has engaged stakeholders in a notification process to include the healthcare coalitions, the Colorado Hospital Association, the Hospital Emergency Preparedness Coordinators, the network of statewide, regional, and local public health emergency preparedness coordinators, as well as the RETACs, and the Governor's Expert Emergency Epidemic Response Committee. There were no factual or policy issues encountered throughout this stakeholder process.
Does that complete your presentation?
Yes, ma'am.
Do any of the board members have any questions for staff? Dr. Pastor.
So I'm great work on this. Emergency preparedness is really important. And it's rare that sometimes we get government where we strike out regulations, and more rare that there's consensus upon it. So great work on this, really. Work.
Thank you, Dr. Pastul. Anybody else? Ms. Nelson, do we have anybody signed up from public?
There is no one signed up to testify.
Thank you very much. That being said, I think we will close the public comment, and we'll move right on to board deliberations. And if there are none, I would ask for a motion. Oh, sorry.
I did want to add one comment.
Yes.
Having worked at the local level for 6 years in emergency preparedness, I would agree that working with the RETACs is really important, but asking them to do these things was not ever particularly effective. So I think it's a good move.
Well said. Thank you. Any other board members would like to make a comment? If not, we'll entertain a motion. Dr. Pastula.
Like that. So I move to adopt the proposed amendments to 6 CCR 10.9-5 rules and regulations pertaining to preparations for a bioterrorist event, pandemic influenza, and so on. Along with the statement, basis and purpose, specific statutory authority, and regulatory analysis.
Thank you, sir. Is there a second? Second. And we have a second from Mr. Engels. And all any comments, discussion from the board? If not, all those in favor, please say aye.
Aye.
Those opposed, same sign. Thank you all very much.
Thank you. Great job.
Thank you.
Thank you.
Ms. Hammond, thank you very much. Great job with that.
My pleasure.
All righty. Well, we are cooking with gas. So let's close the rule-making hearings portion of our agenda today and move into a request for approval of funding recommendations. Staff is being invited in, so it's a little early for a break. What would you like to do, Deb?
I have a question on this document.
Okay. Why don't we wait till staff is here?
Okay. So we can move into some of the lunch updates. If
That'd be terrific if staff's ready to do
Are you
that.
all right with that?
Sure.
Okay.
Yeah.
Before I turn the floor over to Ms. Hunsaker Ryan, I just want to let my fellow board members know I had the pleasure of serving as a fellow board member with Jill a few years back, as did Dr. Stasio. I believe that's right, just the two of us.
Yes.
And I will just tell you all that if she's half as good at being the executive director as she was as a fellow board member, then the department is lucky to have you. So I'm very excited for you.
Thank you, Mr. Chair.
The bar is higher than half, but you're half.
Her half's pretty high, though.
Her half is pretty high.
Well, thank you. Thank you for those kind words. I really look forward to working with this board. Oh, Jennifer. I worked with Jennifer previously on the board, and Deb, of course. So I was on the Board of Health from 2013 through 16, I believe. 4 years. Yeah. But anyway, I apologize. I was unable to come last month. I actually came down with the flu that Wednesday. And because I'm the ED of this organization, I have the obligation to say, yes, I had a flu shot. And yes, the duration was much shorter, coupled with Tamiflu. It was only like 3 days, but boy, I was sure down and out that day. So unluckily, my symptoms came on before I could have come in and exposed you all. I know they showed you the PowerPoint that I had given to the rest of the department about the meet and greet, but I'll just highlight a few things in that.
that it's so great to be back here. Like, I feel like I'm back home. I've been a public health professional for about 25 years, almost 25 years. 10 years of that time spent in the Department of Public Health and Environment. It wasn't all back to back, but I worked with Tom for many years. I was a local public health director at Eagle County government. And then I ran for county commissioner and spent 6 years as county commissioner there. And that was so great because I got to work on the determinants of health from a local policy level and look through every lens, transit-oriented development and zoning and all the environmental justice issues, having that hat on. So that really helped sort of my education and just, you know, the lens I look through every day with public health. And of course, Pat and I worked together for years and years at Eagle County. So this is such a great group. I think at the last meeting, they told you about some of the governor's priorities, and they've shifted just a little bit. So I'll just quickly go over those again. So the governor's given every department 3 or 4 priorities, and the ones he's given for CDPHE include air quality, and that's both from the brown cloud perspective and getting into ozone attainment where we're not meeting the federal standards, and also reducing greenhouse gas emissions. And there are a couple of bills moving through the state legislature right now that will give our Air Quality Control Commission the ability to do some more regulation if they pass, both of the oil and gas industry and also reducing greenhouse gas emissions by sector and some of the biggest emitters. He added suicide to our list since the last time we were here, and it's a good thing. I mean, we need to address suicide. We've of course seen clusters. We've seen several areas where they've got rates increasing over the years. I know our public mental health system is really broken. There's a lot of access issues in rural communities. I'm not sure we as a public health field fully understand some of the root causes. So I've talked to staff about doing some analysis in that area and maybe even some focus groups and formative research as we design our programming around it. We also had immunization added, and I think you know this, but Colorado has the lowest immunization rate in the country. We're below herd immunity levels, and there's a strong anti-vaccination movement here. We really would like to target those parents that are on the fence. They've heard some things, they're suspicious, so they just don't want to do it. We're also working with a state representative on tightening up the SIS reporting system and also looking at what other states are doing around the personal exemption, not getting rid of it, but if there are ways to tighten that up as well. So let's see, immunizations. Oh, and then saving people money on healthcare. The governor created this office with the lieutenant governor to save people money on healthcare. They're looking at different aspects of the system. They're looking at the healthcare system. They're looking at the insurance system. There's a reinsurance bill going through that will really, I mean, that's like if there was a silver bullet that will help folks on the individual market, the small businesses that are just paying astronomical premiums have just been going up over and over and over. And a lot of them have dropped off the market and are now swamping the federally qualified health center system. For CDPHE, it's been more difficult to come up with goals because I tell them everything we do saves people money on healthcare. Like our whole purpose is keeping people out of the healthcare system. So I think we're looking at a few programs that we can focus on, dental sealants in rural communities. The governor is really interested in healthy eating, active living, sort of helping the whole population be more healthy and prevent chronic diseases. So we'll be looking at strategies in that area. You all probably know this, but in my former life here at CDPHE, I'd started the Office of Health Disparities back in 2002 or 3 and was a director of that office for a few years and did the epidemiology leading up to it that cataloged the health disparities. So it's been a passion of mine for a really long time. And coming back to CDPHE, It's amazing that health equity and environmental justice is really spread throughout everything everyone does here, and it's a language that everyone speaks. So we'll continue to look through that lens as we do our work. So we're working on a strategic plan around these goals. I have a couple as well. I'll be adding like reducing motor vehicle crashes, making sure we're ready for any outbreak, continuing to monitor some of the emerging environmental contaminants. But we're also going to ask each division to come up with their own strategic plan and their own priorities, not only feed into these goals, but things that they want to work on as well. So,
Could we ask for you or Deb to send us in writing the governor's new priorities or revised priorities?
Sure.
Just
Yep,
so that
I'll
we've
send
got
them
that
to you, Deb.
reference, and I might even like to have that in our binder if
Yeah.
that isn't too much to ask.
Happy to do that.
Terrific. That's great news.
Yeah, thank
for
you.
that update. Anything else you want to share with the group?
I think that's all. Yeah.
Any questions? How would you like to be? Larry insisted on Dr. Wolk, His Highness, or something to that effect. Is there, how would you like to be addressed?
If not Jill, you can just call me Director Ryan.
Excellent. Terrific. That sounds kind of CIA-ish. Like, I like that very much.
Is that a movie?
I think it is, yeah. I think it's a movie. Any questions?
I wanted to make a comment if I could. I just wanted Jill to know that we have a huge suicide prevention program going on in Eagle County right now. And we're meeting with all the stakeholders and all the organizations that have anything to do with it. It's gotten so big, I'm a little concerned we're actually going to be able to move forward. But it's such a major issue for us, and access is the biggest issue. So we're at a county level, we're moving us forward as fast as we can, but it's huge. So
Thank you, Pat. I mean, I think it's so fortunate having the county commissioner lens, and Eagle County passed passed a tax on retail marijuana to help pay for the mental health system up there because it's so underfunded in the state. And we quickly realized that the funding we were raising wasn't even going to begin to touch it. People have to go 2 hours either way to get crisis stabilization services. It really is an issue in the rural communities not having the access to mental health, behavioral health services. And so what you hate to see is that each community, one by one, has to sort of build their own system from the ground up. But it's what Eagle County's doing, because the suicide rate just over the last 3 years, we're just watching it increase and increase and increase. And the community complaining about just not being able to get care when they need it. So I should probably check back in, because we for sure, as we go about our work, want to be coordinating with the locals and cooperating and learning. So thanks for that reminder, Pat.
We've hired a facilitator who's trying to work with all of these organizations. But one interesting thing is we have a new nonprofit called the Hope Center, which was originally in Aspen, and now we have a group in Eagle County. And they don't do crisis work in-house, so to speak, or in a facility. What they do is work with the potential client where they are. And so they're there with a phone call every 2 hours, or you report into me once an hour, or I have a volunteer that's going to come sit with you for the next 3 days. But anything to prevent people from going to jail, which is totally the wrong place, and prevent them from having to go to an inpatient facility that's 2 hours, 3 hours away and way far away from family, and just makes the anxiety even worse. So they're a wonderful group, and it's a sort of a new avenue, a new way to look at handling potential suicide. So
it's great news. And you said Colorado has the lowest vaccination rate of all 50 states. Was that new information to anybody else, or everybody else knew that?
I knew it was low. I didn't know it was the lowest.
Wow.
What is the reason behind that?
I feel like the anti-vaccination movement has just really grown legs, and people are suspicious of vaccinations. There's a new study I could share with this group that came out. It's from somewhere in Europe, and I can't remember the country, but it looked at the link to see if there was a link between autism and immunizations, and it actually found that the risk for autism was lower, I believe, if the parent had been immunized. If nothing else, it starts to debunk that myth that has just grown legs. one Lancet study. But I think that's the root cause, is simply the distrust of immunizations.
Because I would think Oregon, Washington, California would be that. I'm just surprised we're lower than they are.
And you know, if Tony were still here, he could talk about this too. I mean, I think they've started to do some formative research on the issue, and we want to do that. Like with the registry, we know where there are pockets of unimmunized children by geographic location. So it would be interesting to know in those specific areas what are the barriers or what are the beliefs. So again, before we start crafting any of our at least campaigns around the issue, we want to understand that better.
Yes, I really appreciate that as someone who's taking care of measles and encephalitis. I really appreciate the work.
Anecdotally, both of these two issues that we're talking about are very close to home. We are dealing with an anti-vaxxer who is trying to work really, really closely with our public health department. It's like, what are you doing here, woman? Please just take your attitudes and go away. But now I'm realizing, no, we've got to work with her and change her attitudes. And, you know, I am married to the coroner, and he had 2 suicides by hanging last Wednesday. You know, so that it is both of these issues are just, you know, they're so close to home, and yeah.
Yeah, sorry about that.
Mr. Butts?
Yeah, and you know, certainly that hesitant population seems to be the term we were targeting at the local level anyway, that group that's on the fence. But is it accessible? Is you're able to converse with them, you're able to provide some evidence and hopefully convince them to move that bar a little bit. I think the other thing that I read not that long ago, that there's an inverse relationship between socioeconomic status and immunization. So the smarter and more money we get, the less we tend to believe the science that got us there, I guess, for whatever reason.
In that regard, Jill, is the trend getting worse, or is it we just low and we stayed low?
I actually can't answer that question. I'll find out though. I'll send you the data.
And we have a full presentation on immunization coming to the board, and I think it's July is what we have it slated for. So we'll be able to sort of tie this into those strategic priorities at that point in time, as well as show the dashboards, because there are so many new tools since even a year ago for a constituent that is on the fence to be able to learn more and what's going on in my community, my school. So we were going to have staff demo those for you.
That's great news. Well, Director Ryan, it's a pleasure to have you. I'm glad you're over your flu, and thank you for that great update.
Thanks, Mr. Chair.
It is hard to find Webb in the room. I can't find that jacket. Is Webb here? Oh, there's Webb. Man, that jacket is fantastic. Are you all ready? I know we're a little early, but I'd love to bring you up if you're ready. Great. All right. So Jen will come back to you in just a little bit, if you don't mind. All right. So now we're going to do a request for approval of funding recommendations. There is board action required. All 4 members of the public are welcome to observe the request. However, oral comments are not received during this time. Please contact the staff identified below if you want to provide feedback about the proposed changes. So staff, if you would please introduce yourselves and proceed.
I have a question on conflicts of interest.
Just a second, Webb.
Sorry. My county is listed as receiving a grant, so should I not vote on this?
So it's up to you in terms of it can be a disclosure. So it's for your peer board members to know if you can evaluate the project fairly. If you think you can and you would like to participate, you're welcome to. If board members would be more comfortable with you not participating, you can abstain. Relatedly, just, you know, so that folks have an understanding, these grants were well underway in the process before Jill was named as the executive director. This was not Webb trying to work some magic or anything like that. So just also throwing that out there so I can include it in the minutes. I just want the public to understand that we were well underway.
So I do not work for the Department of Health. I work for the Department of Human Services, and I've had nothing to do with this grant, although I hope that the wonderful effects of it will filter down to my little program of veteran services. But I'm not directly involved with the grant in any way. So I think I feel comfortable voting on it as long as the rest of the board is.
Does anybody feel uncomfortable with Ms. Hammond participating? Seeing none, that would be terrific if you could continue to participate. And now, staff, if you're ready.
We are. Webb Brown, Director of the Office of Health Equity. Good morning.
My name is Jamie Hiyakumoto. I'm the Health Disparities Grant Program Manager.
Thanks for being here.
And first, the jacket. After the winter that we've had and surviving my first bomb cyclone last week, which I had never heard of until last week, and the fact that my baby girl, who is 9 years old, bought me this jacket for my birthday in January. Well, bought me this jacket.
Where does she think she gets her money?
She made me promise to wear it today, so here we go. But I am warming up to it. I kind of like.
All right, well, hold on. I'm gonna send this to you.
Oh my gosh!
As proof. Okay, go ahead.
Thank you very much. That's actually going to be really helpful. So, grant program. So, we had the pleasure of bringing our first round of grants to this body a year ago that represented a new direction for the Health Disparities Grant Program, moving from more direct clinical services to a more upstream focus, with the belief, and according to the data, that the upstream work was really where we needed to focus our attention if we were serious about addressing the issue of health disparities in Colorado. And so you approved 9 grants approximately 12 months ago that focused more generally on upstream determinants, more broadly defined. We took the lessons learned from that process and that review, and have refined the focus area of the grant to be more focused on the issue of housing, specifically affordable housing and land use planning. And so today we bring before you 5 applications that focus in this specific area. And so I am going to, and then lastly, we had the pleasure of having a really great discussion with you last month about the evaluation plan for these projects. Brought before you the evaluator to talk about how success is going to be measured, the long-term approach that's necessary in terms of moving the program in this direction, in terms of determining what success looks like. And so I feel like we were really well set up for today's discussion based upon the discussion last month. So with that, I'll turn it over to Jamie to walk through the 5 that we bring before you today.
Thanks, Webb.
There it is.
There we go. Thanks, Webb. So today I'll go through an overview of RFA 11545, which was for the Health Disparities Grant Program for a 2-year grant cycle, FY 20 and 21. Talk a little bit about the application review process, and then a presentation of the slate of applications recommended for funding. So if you look at page 3 of the Board of Health memo, we outlined our strategic framework and how we got to it. Basically, the Health Disparities Grant Program was seeking to fund lead agencies with existing partnerships to work on systems and policy changes that are community-led, that address housing and land use planning focused on affordability and reducing disparities, reducing displacement, segregation, and gentrification. So there were 5 major components of the RFA. The first is they needed to identify the upstream determinant of health they would work on, either land use planning or affordable housing. They needed to identify the system or policy change that they would work with their community on. They needed to identify a lead agency who would be the one that CDPHE would contract with, who also had programmatic and fiscal compliance experience. They needed to identify the multi-sectoral partnership that was involved in this project. So for example, it could be housing and health. And then they needed to just demonstrate authentic community engagement, so how the project would be community-led. We have $3 million to spend, or $1.5 million per year. We reviewed 9 applications, and those 9 applications were requesting approximately $2.8 million. So the timeline for all of this, the RFA was released on September 12th. The applications were due on October 13th. The Office of Health Equity conducted a technical review, making sure that each of those 5 major components were covered in the application. So we actually received 13 applications, and from that technical review, 9 of those applications did not meet all of the 5 major components. Specifically, most of them were proposing direct service and did not propose a system or policy change.
9 did not meet?
No, sorry, 4. So 9 went on to the individual review process. We put the reviewers, who were made up of both community external reviewers and then internal CDPHE reviewers, into teams.
Could you describe the reason why they might submit an application that doesn't meet the requirements of the application? Did the requirements change, or unclear, or try to sneak one in?
That's a great question.
It's been my experience. I have a 10-year history of working in philanthropy prior to this job, and especially during difficult times, or when an agency is just having difficulty bringing in financing or funds, it's not uncommon to submit an application and just see what happens, especially if it's one that you don't have to spend a whole lot of time on in your estimation, something that you've submitted before. Take it, kind of revamp it a bit, and throw it in for the Health Disparities Grant Program, see what happens. So there was certainly an element of that as well.
Thanks.
I think also we had funded direct service programs in the past, and what we found from the last funding cycle was that the field wasn't quite ready for this type of work. And so I think some of the terminology and the way that the program is, the strategic plan of the framework for the program now is so different than what it was before, that I think that's also could be a reason.
Thank you. Sorry to interrupt.
No, that's fine. So let's see. We had 4 teams, 3 reviewers on each team. They each used a scoring rubric, did an individual review of all of the applications that were assigned to their team. From there, it moved on to the team review, where the teams got together, they discussed the applications they were assigned. They assigned a team score to each of the applications, and then made their recommendations for highly recommend for funding, recommend for funding if funding is available, and then do not recommend. After that, we went into our funding conference. That was February 6th of this year, and presented all of the 9 applications to the Health Equity Commission, had a discussion with them about each of the 9 applications, and then they met to vote on projects that they are recommending for funding. So that was our process. The 5 grantees are Chaffee County Public Health and Environmental Health, City of Fort Collins, Eagle County Public Health and Environment, Lake County Public Health Agency, and United for a New Economy. And again, they are requesting $2.9 million in total for over the 2-year cycle. Chaffee County will educate the public about land use planning strategies that affect affordability, talk to individual groups affected by housing issues. So they're planning to talk with developers, realtors, business owners who are losing employees due to housing, planners, and then also the affected community. They'll take that knowledge and feedback and then help use the surveys that they'll be taking with those groups to decide on zoning and land use codes that need to be changed. The City of Fort Collins, they will advance the work in the city to look at plans and codify land use planning and zoning codes. The community will be engaged through grassroots organizations who will take a leadership and training course around what the issue is around housing and learn about land use planning and codes, and then will take the lead in the effort for that policy change. Eagle County will be working with the mobile home communities there to identify needs and possible solutions. They'll work with the housing department to establish a community land trust. They'll update the affordable housing guidelines using an equity lens. They'll complete a housing assessment to look at rentals, such as people renting a room in a house or short-term rentals. I'm thinking like Airbnb, to understand the capacity and volume within that county. Lake County is going to be forming a policy advisory team made up of community members, land use planners, a planning commissioner, a real estate agent, and a local developer. They'll identify a set of changes to municipal development and land use code in the city of Leadville and also Lake County to preserve, protect, and expand affordable housing that can be presented to local government for adoption. And then lastly, United for a New Economy is working very closely with the Globeville, Elyria, Swansea Coalition. They, with the community, will create an equitable development plan, and that is a plan that meets the needs of those who are underserved in their community through policies and programs that reduce disparities. They'll develop the healthy community stewardship of the GES Coalition, or the Globeville, Elyria, Swansea Coalition Community Land Trust that's already been in development. And that will help to stabilize the families in that neighborhood and communities at risk of displacement. One of the really cool things about this project is that one of their plans is to reach out to families who have been displaced already in that community, and through this land trust try to bring them back. So those are the 5 projects that we have in front of you.
And
oh yeah, Grand Wood, Denver.
Yeah, I'll let you do that. Okay. So just to add a couple of last comments, Jamie mentioned the fact that when we made the decision as a program, as a grant program, to go in this direction, that there wasn't a lot of readiness in the field from our estimation, from informational interviews that we conducted for this type of program. And so we knew that and we understood that. However, we're really excited with where we've been able to get to between last year's 9 and this year's 5 applicants that we're bringing forward. But we also understand that we have a responsibility as it relates to building the readiness and knowledge of the field in terms of this sort of programming. If, again, we are serious about addressing the issue of health disparities. And so one thing that we didn't get into last month in our conversation with the evaluators is just the role that they're going to play in terms of that field building piece. So they are going to be documenting the results as well as the type of community level changes that have taken place over the life of these grants. And we have a responsibility to make sure that those findings are disseminated far and wide. Obviously, most importantly within the state of Colorado, but also on a national level, because this type of grant making is so is so new and innovative, but really important when it comes to addressing the issue of health disparities. So there is going to be a certain level of field building in terms of knowledge and capability that we are taking on as a result of this funding program moving forward as well. And then the last piece I'll add is that I'm sure all of you have heard of the Colorado Health Foundation, the largest foundation in the state. They conduct a symposium once per year in the summer in the mountainous area to bring together folks to share information to always picking a different topic each year, whether it's mental health or health equity or what have you. This year, they're focusing on affordable housing at that symposium. Now, I'm not going to take credit for that focus area that was decided upon by the foundation, but what I will say is that they've had a lot of questions for us in terms of our strategic direction and our grant program over the course of the last year prior to deciding to move in that direction. So the fact that this program is having some level of influence in terms of a really large funder such as that, who is in constant contact with us about our program and our focus area, I think it really bodes well in terms of where programming in social determinants, and particularly the upstream determinant of housing is going. So just wanted to relay that information to the committee as well. So.
Great. Any additional information you wanted to add?
Yes, I did want to add that United for a New Economy has requested to change their lead agency to Groundwork Denver. Right now, they're a nonprofit advocacy organization that has taken on the GES Coalition that is not its own nonprofit as a fiscal agent. But between applying and now, GES Coalition has decided that they will no longer need a fiscal agent because they'll form a nonprofit through the Community Land Trust. So one of the partnering agencies, Groundwork Denver, is stepping up as the new lead agency. So just a change on there.
Yeah, so if the board chooses to move forward with this, I've got a motion from Deb that's written to include that change. So
thank you.
We'll make sure and capture that. Anything else?
No, I think that's it.
That's it.
All right, I have a little bit of feedback for Steph, but I'd love to open it up to board members first. Any questions or yes, Mr. Turk?
Here we go. Just a general comment, because part of my sordid past, I was a land use planner in the city of North Glen. So I'm really excited to see some focus on that policy aspect and how land use planning kind of affects the larger picture. So I'm really excited to see kind of what goes on with some of these grants and to hear, what they're doing and some of the outcomes. So I just kind of wanted to reiterate that to the staff that you're excited about the innovative work. Me being a policy and planning geek, I'm excited to see some of this as well. So thank you for kind of moving forward in that direction and being willing to kind of step outside the box and look at some of these. So I'm excited to see where these flush out. So
Commissioner? Thank you.
Yeah, if I may take that excitement to the next level, though. And one of the things that I was a little bit concerned about in looking through this is I didn't see a whole lot of buy-in from the elected bodies of these organizations. That when you have community organizers and even staff involvement, when you don't have the city council or the board of county commissioners backing these, my concern is that you develop a really good set of documentation to move forward that sits on the shelf. And I heard everything that you said about this being new and innovative and a lot of work in getting some good groundwork for stuff moving forward. How much involvement are you going to be asking these groups to get their elected officials behind the plans that are being developed out of here so that they don't end up just collecting dust once the deliverables are done?
That's definitely something that we were looking for in these applications. And have had conversations with each of the grantees to make sure that one of their partners at least was located within the body that can make those policy approvals. So I feel like all 5 of them do have that connection. And in fact, United for a New Economy was an applicant in the last round that did not have that piece, and they were not funded in the last round. And for this round, they really made sure to address that in their application this time. So.
And just to piggyback on that, I would say that during the review process that took place with the Health Equity Commission, if there was a major theme that went in terms of comments that went throughout each application, I'd say you just hit on it. And that was a concern for them as well. So we made sure that during the review process on the final stage, that was something that we were considering. And there were some applications who were not funded in this round for that very reason. So we have a pretty strong belief that these were the strongest in terms of the exact issue that you're raising in terms of having elected officials buy-in. So,
well, boy, howdy, that is really, really good feedback, though, Commissioner. So, so in the project management world, it would be an executive sponsor of sorts. What I'm hearing the feedback that you're providing is in this sort of a forum, having an executive or a community sponsor that is going to help at that level in their community to really advocate for the success of this is of utmost importance.
Yeah, reading through this, the measures of success are really produce the documentation, not implement the recommended outcomes. Gotcha. So it feels like minor verbiage changes, but it really is critical to making this a success. That I've got some really great land use changes, but if I don't have a board that's going to say, yes, implement these, make sure that the next developer that comes in has his feet held to the fire to make sure that the affordable housing happens in this development, then it's just a set of recommendations that sits on the shelf.
Yes, absolutely.
Director Ryan?
I'm just wondering in your grant process in the future if it might be worth requiring a letter of support if it's a governmental entity. Just because, for example, if it's a board of county commissioners, they would have to vote to actually send you a letter of support. And it's one way to engage them and maybe get some accountability around it. Do you think that would help, Ron?
That would be fantastic.
If there's an elected body involved.
Excellent.
Very good feedback.
Mr. Butts.
Thank you. One of the challenges I've experienced previously with working on affordable housing in counties is they don't have much in the way of leverage or levers that they can control to encourage or support development of affordable housing. I didn't know if, as part of your backdrop, you looked at sort of where the authority and responsibility lies and whether these folks are engaged with those community members that have that authority or responsibility. It looks like the county-based initiatives are looking at their planning authority, not necessarily their housing authority. So,
I would need to look at that a little bit more closely, but I do know that there are, like, for example, the city of Fort Collins, one of their co-leads is the housing authority. But I would need to look at that a little bit more closely. Thank you.
yeah, I think as housing becomes a public health challenge in a way, understanding the system and the obstacles in that system to support housing initiatives is really important.
So just a friendly amendment, the staff will review that. I think that it's possible that it's in there, and then when we wrapped up this document in a summary fashion, so sort of flagging it for you so that when you are doing that negotiation on the scope of work, that if it needs to be about the land planning and the housing planning, so we can break that down. So to the extent that the RFA asked for that, and that's how the application came in, let's just make sure we're seizing it. And if not, it's a lesson learned for next time.
My feedback is more specific to the, let's look at page 11, just as an example, to outcomes. So I have beaten this drum for a few years, but I want to make sure that you all are thinking about anticipated activities and outcomes. Folks frequently talk about SMART goals, and SMART being an acronym. Measurable outcomes have got to be SMART measurable outcomes. So outcomes, for example, increasing capacity of staff, decision makers, and residents around policies that impact health. Golly, that's super nebulous and sort of generic, and I don't know how you that doesn't seem measurable at all. So if it's an opportunity to say, so a SMART measurable outcome is, in strategic planning, VMOTOMO is an acronym that we use a lot. So vision, mission, objectives, tactics, action items, and then measurable outcomes. And the measurable outcomes tie back to your vision and mission. So a little bit like when Director Ryan was talking about, okay, so the governor has these priorities. As the executive director, I now have these priorities, and I'm going to ask all of my programs or departments to have 3 or 4 strategic priorities that then, in essence, serve to my priorities, which serve to the governor's, right? Would you agree with that? The measurable outcome on those priorities, just like in a grant, have to be measurable. So we're going to take it from 5 to 10. We're going to take it from 2 to 100. And we're going to do it in a set amount of time. So if you take these sort of outcomes that you've committed, or that the teams have committed to you, and then add some more specific expectations to them from the very get-go, so you're really clear about, well, what does increase in capacity mean? And have them better define that for you in the front, so that then that can be managed over that 2-year period. I think that you'll see there's added investment from the teams. There's added input. It's easier to talk to your community members about the progress that's being made, and then you'll be able to measure that a little bit better as well.
So we work
If that
with
helps.
the Peer Center through Kaiser Permanente, and the outcomes and the activities in here come from the applicants themselves. But we'll be working closely again with the Peer Center to develop their 2-year evaluation plan. And Kaiser has developed a standard set of metrics that the grantees will be using across, well, now all 14. And so I think it'll tighten up.
That's terrific. That's great news.
They'll be reporting semi-annually on those metrics across all grantees.
Excellent.
I couldn't agree with you more on that request. And you have to have a baseline to measure against.
Mm-hmm.
You got to have 2 or 10 to start with.
That's exactly right. And know what your baseline is. Yep. So that's great information to hear. Thank you. Other feedback from board members? Staff, anything else for us? All right. So should I read the disclosure, or did you cover that
I already
well
covered it.
enough? Okay. All right. So the motion on the table is, so I'll make the motion. I move that the board approve the Health Disparities Grant Program funding recommendations in the total amount of $2,934,570 as described in the March 18, 2019 funding recommendation memo. However, Groundwork Denver will replace United for a New Economy as the lead agency for the Globeville project. The approved duration for the grants is July 1, 2019 to June 30, 2021. The final award amount may be adjusted as the scope of work for the grant is finalized. However, it will not exceed the total 2-year grant project amount delineated in the funding recommendation memo. May I have a second?
Second.
Thank you, Ms. Hammond.
Poor Ray.
Should I?
It's cold.
You're slow on the uptick. All right, let's see. So all those in favor, say aye. Aye. Any opposed? Same sign. Hearing none, the motion carries. Thank you both very much for your
Thank
time
you very
today.
much.
Great presentation. Almost as good as the jacket. I'm going to send it. I don't actually have your numbers, but I'll send it to Deb, and then Deb can send it. Thank you both very much. All right, so we are at 11:54. I am told that the presentation that we have in some of our other updates is ready to go. But how about, since lunch is here, we take a 10 or 15, 10-minute break? Let's take a 10-minute break, use a bio break if we need it, and then grab our lunches, and then we can be eating while the presentation and the updates are provided. I think everybody's here.
Hang on.
Oh, sorry.
That's okay. Now, Jen.
Thank you. Not much of an update. Just want to let you know on our medical marijuana John Doe's doctor's case that's in the Colorado Supreme Court. We're busy briefing. Our brief all briefings should be completed by the end of April. And I don't know if I mentioned this before, but you might find it interesting. So there's a corresponding case against the medical board where these doctors are contesting the investigation from the medical board based on the referral from CDPHE. And the Supreme Court wants to hear these cases together. So when we argue them, it'll be a joint argument. So yeah, it'll be very interesting. I'm not sure when that will be set, but I will keep you posted.
Board member reports on committees, then we'll put those off as well unless, is there anybody that needs to leave earlier than expected today? No? Fantastic. Okay. Well, then let's honor the time of the team that is here to talk to us today about nursing sensitive measures, data collection, and the hospital report card. If you could all please introduce yourselves and then proceed.
I'm actually, my sole role is to use the mouse and introduce them. So I'm Grace Sandino. I've been around the department for many years and am currently a policy advisor in health facilities. Gail Finley is with the Colorado Hospital Association, but prior to that, she spent 10 years here as my boss, my mentor, and my friend. So when she left CDPHE and went to the Hospital Association, she's now the vice president of rural health and hospitals. And so she deals extensively with the rural and frontier issues that are rural hospitals and health centers face. She is also has a variety of other hats, and one of them has been the link to CDPHE in the hospital report card and the nursing sensitive measures. She has been on a variety of different committees and commissions, task forces, you name it. Gail has been the CHA representative and represented the interests particularly of the state's rural facilities. Colleen Casper.
You're Gail? Hi, Gail.
Sorry.
Thanks for being here.
Colleen Casper is the executive director of the Colorado Nurses Association and has been that now for 5 years. She has both a master's and a doctorate in nursing practice and has provided leadership in a variety of roles for improving work environment, increasing shared decision-making for nurses, and also in education and patient safety. And so she is here to help address the nursing sensitive measures, which are part of the hospital report card that you're going to be hearing about.
So some people are doctors or nurses. You're a doctor nurse.
Correct.
That's fantastic. I like that very much. Please proceed.
So I'm Gail, and I will speak first. And I wanted to go off script a bit and thank you for the continued focus on suicide prevention, and that I hired the first person that started the office here at CDPHE when I was here. So I think I'm much more discouraged that we've not made a dent in the statistics across the state, and the impact in rural is pretty darn significant. So I appreciate the continued work in that space. Just so you know, just can't help it. It just irritates me to no end. For all the efforts and I mean, there's passion that's in that space, and I'm sorry to see it still in the state it's in. But I am here today to represent the Hospital Association and our 100+ members around really the nurse-sensitive measures, which I realized are collected and reported within the hospital report card. So thought it best if I gave you a bit of information about the hospital report card so you understood the timing and context and how it all relates. And we'll be showing you the web pages so that you can see the layout and how that works. What I don't want to do is make an assumption that you all know about hospitals. So when I said we have over 100 members to the Hospital Association, we represent both the hospital systems, so the Centuras, Banner, SCL, UC Health, but we also work with the individual hospitals, both general acute care hospitals, critical access hospitals, long-term acute care hospitals, rehab, and psychiatric. So not all of them that are licensed in the state are actual members, but the majority of them are. But we do work in that space. So the hospital report card, however, only represents the acute care facilities. The psychiatric facilities, rehab, long-term acute care are not included in the hospital report card. There is information about pediatrics that's in the hospital report card, and that applies to those that actually provide some of the services to kids that will show up in the report card. So the report card was created by legislation in 2006. It was House Bill 1278. There are links to it on our website, which we'll show you. We were given until November 30th of 2007 to actually release the first report card. This was actually one of my jobs when I was at CDPHE, was to get this report card off the ground. So I worked with the Colorado Hospital Association at the time to put it together. Dr. Kalange and I were kind of the leads on it out of CDPHE. I have to tell you that a lot of that just went right out of my mind when I didn't have to do it anymore. But I picked this back up, needless to say. And it was interesting to look at old emails along the way. The idea for the hospital report card was to view and compare data for specific hospitals for the consumer. So that was the whole idea, is that there would be, this was a first venture into transparency for hospitals, and that there was a presumption that people were interested and wanted to go look at outcomes, and clinical outcomes is what they were very interested in looking at the time. So the legislators who brought this bill forward actually put an emphasis on that ability to look, self-look at, self-refer, go to it, take a look at it, and be able to make some comparisons. Needless to say, that led to a lot of work around how do we make it so that it's usable by people who are not clinical. Not everybody knows the terminology, et cetera. So there was a lot of work that went into creating something that was hopefully usable by a consumer. CHA actually conducted focus groups with the public, trying to get an idea of what they understood and didn't understand and what they were interested and not interested in. So the first couple of years was a lot of activity around creating it. They created a special committee that worked on it, to identify what would initially go up. So the first release of it was by November 30th of 2007. It includes clinical outcome data, and the groups, the initial versions of the report, and really today's versions of the report include information about common procedures and surgeries around, the total number of them, infection rates and mortality rates associated with each of them. It includes a variety of medical conditions which have come and gone over time as people decided something was important or not in the first few years, and looked at the mortality rates for those medical conditions. It also created mortality comparisons for various procedures and medical conditions, so that you could look at things across okay, across the board amongst the hospitals. It took into account low volume hospitals. So as I talked about types of hospitals, one of the types of hospitals we have in the state are critical access hospitals. They're found in rural counties and rural areas of the state. They have 25 beds or less. And so their volumes of patients are typically fairly low. And to do comparative analysis of their volumes against larger facilities has always been a conundrum about how to do it. So what we did with the low volume facilities was just gave overall mortality information. It was just, for those of you in the numbers game, might understand what that's about a little bit better than probably I do. I'm not the epidemiologist. It includes patient safety measures, pressure sores, blood clots after surgery, sepsis, and then fall information. Okay. And then infection informations. In this particular data set, we include the central line infection rates for hospitals with ICUs. The pediatric measures tend to look at special populations and specific data related to kids. So you'll just need to go out, like there's diabetes, asthma, length of stay, a couple of things like that that you can go look at. And then there was obstetrics outcome data. So I know there's been a lot of press lately about obstetrics, particularly in rural areas. There's been a big story about it. But for those of us that have been doing this for a very long time, we know that a lot of rural hospitals quit doing obstetrics in the 80s. So there's been a lot of hospitals that have not done obstetrics for years and years and years in rural areas. And it's more, we can't tell if it's just new researchers that didn't know that, or, because they're all younger than I am now, or what. But in essence, there's certainly been a new emphasis on the fact that we've got rural hospitals that had maybe been doing it that also stopped doing it in more recent years for one reason or the other. Usually it's volume. I mean, it's hard to maintain quality for some of the quality metrics that are expectations that there are and the complications that you can have. There are some metrics out there that say you need to be doing about 150 a year for a financially viable obstetric service, but you need to do about 250 to have the quality, meet a quality metric. So it's a kind of, in many ways, a more dying art than it is a growing one, much to the chagrin of a lot of community residents who remember being born and their kids being born in that local hospital and can't figure out why they're not doing it anymore. So one of the conundrums. But in this area, for the hospitals that had obstetrics, you will see some measures around birth trauma that may have occurred with or without instrument. I mean, things that clinically, as a non-clinician, know that I'm not a nurse, it makes it a little more difficult for me to explain what it might mean to do a birth with or without an instrument. I didn't have any instruments when I had my birth, so I can't even tell you. For those of you that might want to know more about it, I'm sure we could find somebody that could help you with that one. Anyway, once we got it up and rolling, in essence, it's really been on a maintenance mode since. There's not really been too many changes from those first few years. The data, other than there was a point in time where all the health systems switched from ICD-10 to ICD-9 to ICD-10. Everybody know what that is? Right, the codes. So, but it's the codes assigned to the diagnostic codes assigned to the cases. So that created an inability to do the risk adjustment that we were used to doing prior to the publishing of the data. So there was a gap. There's been some gap in some of the data over some years because of that. And then there was a change in the reporting requirements out. The original bill required that we did a report to the legislature and to several other entities for a number of years. And in 2017, the legislation passed that changed the reporting requirements to the governor and the public via website. So there's just been different reporting requirements out from us. So I actually was going to turn to Colleen to talk about the implementation of the nurse sensitive piece of legislation and the background to that. And then I can pick up on how CHA, then what we did with it.
Great, thanks. Sean.
Good afternoon. Thank you. Good afternoon. I'm Colleen Casper, representing the Colorado Nurses Association, which is an advocacy membership-driven organization that represents the interests of all licensed LPNs and RNs in the state of Colorado. And personally, I've lived and worked in Colorado hospitals since 1979, everywhere from Eads and Burlington to most of my career has been in Metro Denver area. But I am grounded in the rural gems in Colorado. So I'd like to begin by quoting from a 2007 Colorado report of the Governor's Task Force on Nurse Workforce and Patient Care. This was a task force commissioned by Governor Ritter. And the lead quote in that report, which is certainly available online or we could get it to you, is "Nursing is vital to patient safety and patient care. Any attempt to improve patient safety and quality of care must take into account this fundamental component of the healthcare system." So all of this work we're discussing today has one primary goal, and that is to drive effective policy making and/or sustainable problem solving. Our preference and recommendation is to assure that we rely on accurate data to inform both the definition of the problems we want to solve and the methods to improve patient outcomes, regardless of the care delivery setting. It's widely recognized that nurse staffing alone is not a reasonable single approximation of workload, though it does serve as a visible metric to frontline direct care providers, that is the RNs, the LPNs, and the certified nurse assistants who work on the front lines of care. We recognize that working conditions and environments influence the workload of a direct care provider also. Research is clear that fewer patients per nurse or more direct nursing care hours per patient day is associated with fewer adverse outcomes. In particular, mortality and failure to rescue are impacted most predominantly in surgical and intensive care patients. What we do lack is clarity about what specific facility level strategies can impact nursing workloads. Much of that is because we lack consistent measurement of data and, more importantly, the comparative analysis of that data to determine the factors that effectively improve staffing plans and patient outcomes. We don't want this report to sit on a shelf and collect dust. Senate Bill 10 of the 2007 Colorado legislative session would have required each hospital to develop, implement, file with the Department of Public Health and Environment, and make available to patients upon request a facility staffing plan and state the minimum levels of RNs, licensed practice nurses, and other personnel. This bill did not pass. Senate Bill 08-196 that we're talking about today reflects the compromise that was reached by the stakeholders, that Governor's Task Force, in 2007 in lieu of mandatory staffing ratio legislation. The inclusion of nurse-sensitive measures in the hospital report card is an attempt to show attention to the need to monitor and address nurse workforce retention and recruitment, and to advance the conversation about work environments and staffing based on data, trends, and importantly, the comparative analysis of Colorado hospital staffing and work environment measures. In closing, as a director of Colorado Nurses Association, I continue to have conversations with direct care nurses in all settings as recently as this week, related to the following hot topics: salaries that reflect the cost of living, mandatory overtime, restricted overtime, or that is overtime that's not approved or worse, punished, and yet providers unable to complete their work without the overtime, and concerns about nurse-patient ratios and workforce shortages. I can't say enough about how much I appreciate the work of Director Randy Kuykendall, Colorado Department of Public Health facilities staff, and Gail Finley, the Colorado Hospital Association staff, over the past 2 years to resurface this effort to assure monitoring of nurse staffing and work environment for patient care. We look forward to engaging with the Board of Health in efforts to analyze this data and offer recommendations for statewide improvement. Thank you.
Back to me. So just so you know, there was a governor's task force that was formed out of which this was created. So again, we can make sure that report is available to you to take a look at. So when the bill was created, it was actually embedded into the hospital report card statute. So I believe you've been given a copy of it so you can see what that language was like, which meant that we needed to incorporate it into the hospital report card at the time. So work was done to do the programming, et cetera, that was going to be needed to do that. And the collection of data started in early of 2009 in response to the passage of the bill. So, and some of the research that I had to do here, because I actually did not have much to do with this report card in between me leaving the department actually and going over to CHA, that wasn't within my task. But what I did find out that the work group actually struggled a bit with, and we've tried to figure out what to do in this space, actually had to do with some of the definitions that ended up being adopted and used. I found correspondence between CHA and CDPHE where there was discussion about the fact that many of the definitions and inclusion and exclusion criteria for some of the measures that were going to adopted were proprietary. They were owned by the NDNQI, the National Database for Nursing Quality Indicators, and in essence, we couldn't use them, even though that was the benchmark that everybody wanted us to be collecting data by, because that was a big database, a national database, and that these indicators were included. So now it makes more sense to me why some of our definitions that we've used since 2009 are somewhat different than the NDNQI or the NQF information that was out there when we started this project. What I found out that is done is in contacting the 30 hospitals that are doing the data collection right now, they're having to collect both definitions worth of information. So from an administrative standpoint, they're doing both in order to meet their obligations if they have it with NDNQI. And I think it's 24 out of the 30 are doing NDNQI. So they're doing both definitions, and then the others are just doing our definitions that are not reporting to NDNQI. But it has made an interesting, I guess, an interesting finding for me to realize that we had that issue. We also had to create the data collection tool for the practice environment scale, which Colleen spoke to, which is a tool that's supposed to, again, look at the environment within which the nurses are practicing. And is this a collaborative practice environment? Is this, is this working? Is my day-to-day work going well? Am I included in decision-making? What's my role? So it's actually a survey that is sent out by nursing leaders to the nursing staff, and they are all encouraged to complete the survey. It's online. They don't see it. It comes directly to CHA. And for the hospitals to actually get the results of that survey, they have to contact us and get the results back to them. So that took a little bit of time to put together, so we had some consistency again in what we were collecting and from who. So once we got those things in place, we've basically been in maintenance mode on this particular aspect of what we've been doing, because the measures were very specific in the statute about what we needed to collect. Where we maybe made changes was both in the definitions and maybe when we collected the data. So the PES, or the practice environment scale, is only collected on odd years, and the RN education information is collected on even years. And then the skill mix, nursing care hours per patient per day, voluntary turnover, patient falls, and falls with injury are collected on a quarterly basis. Okay, so there's different ways that we've been collecting it, but we've been doing it basically the same way. It is not a system where we're going out and validating what they submit to us. What they submit to us is what we report. And in essence, this is another one of those things where we weren't necessarily funded to do this activity. So as
Not funded at all.
yeah, well, that's we chose to do it on behalf of the hospitals and work with the department to pull it off and work with nurses. So on the nurse sensitive metric part, we were actually required to have a working group that had a minimum of 5 bedside nurses involved in helping decide what we're going to collect and how. They were governor appointed at the time. And so it was a big deal in who we worked with and how we did it. And it's important to have that bedside nurse deal. I mean, know that in the majority of my work in the nursing area, because I also do workforce, it's been around with nurse leaders and with policy makers who have all helped educate me to a great, great degree around nursing practice. Bless you all.
So you know that the nurses really do the hard work.
I agree.
Just seeing if Dr. Festula was paying attention.
Props to
Okay.
the
go ahead.
RN on that side of the table.
I just know that we couldn't do it without them.
That's right.
We just couldn't do it without them. I mean, I think that as we get further along here, I'd like to spend a little bit of time talking about some of the workforce shortage issues and the specialty nursing issues that we've got, and talk a little bit about our conversations we had in that space because it's such a big noticeable issue. So I don't want to ignore that that's there at all because I don't, it ebbs and flows like a lot of workforce things do, but it impacts us pretty significantly when it's happening.
Does anybody ever think that it's about nursing mothers when you call it nursing sensitive measures? Or am I literally the only one who on the agenda thought, oh, we're getting some more data about, so does that ever come up as a different way to call it or something
Baby-friendly
else?
hospitals on the brain is what's
Yeah,
really-
I think we got that
Yeah.
presentation last.
You hear about it.
Yeah.
Okay. I've never had that come up.
Okay, just
Mainly
me.
because I'm usually being talked to, I mean, usually this conversation around this is within the nursing community or the medical community or the hospital community. So it's not usually the general public that's asking about these measures and metrics. And one of the things that, so let me not skip ahead too far yet, if I can. But no, not that I know of.
No, but congratulations to you for recognizing the importance of baby-friendly hospitals.
There was a whole presentation. Yes. And it was wonderful.
Oh, goodness. All right. So a couple of years ago, it was brought to our attention in 2 ways. One, there was a report that was generated out of the Colorado Center for Nursing Excellence, which is the nursing workforce center in Colorado, that they had done an analysis and looked at turnover. And their data differed from our data. And we supposedly got it from the same source. So that was an issue that got identified, partially impacted by definitions, I found as I looked into that, but I don't think it accounted for the significant difference in the data. And then the other issue is that we started having conversations again down at the Capitol. Senator Aguilar, thank you. Senator Aguilar was looking at running a piece of legislation again around nurse ratios, patient nurse ratios in critical care units, I believe at the time. And we were having another conversation about where we should go with that issue. And we thought at least first, let's sit back and look at this information and what we're collecting and see whether that's the path that we really need to go down. So, in essence, what I did was agreed to kind of lead the work again in this space and decided to kind of reinvent the nurse sensitive measure work group that had been created before. I contacted our large facilities in the metro area and asked them for a bedside nurse that could give me, a day a month for 6 months or so to kind of revisit this work. It's hard to pull a bedside nurse away. They needed to be working at bedside at least 50% of the time. And so that's usually someone very involved in patient care. And so it was a big commitment on their part to come and to participate in the work that we did. We ended up with a representative, a charge nurse out of University Hospital, an ICU RN educator out of Littleton Adventist. We had someone from Lutheran Medical Center. We had a woman involved in critical care and trauma at Denver Health, and a representative from Swedish Medical Center. So it was actually really refreshing to work with the bedside nurses, and they've never worked in policy and in this conversation. So it was a kind of a nice mix. And then I had two representatives from the Nursing Association, Colleen, and then John Weldon, who's a professor in the Colorado School of Nursing at the University of Colorado, a renowned researcher really in nursing workforce issues and practice environment scale issues. So it was great to have him involved. And then we had a representative from CDPHE. Grace stepped in here around Christmas time, and so got to attend the last couple of meetings with us on the work that we did. And prior to that, we had one of the other policy analysts within the group participate. We concluded our first phase of work in February of this year. As I looked at the work, I realized that there was some short-term quick things that we could look at doing. So we kind of called that our first phase. And then we looked at, we're going to do something next. But as we started that first phase work, what I had us do is go through and look at each of the metrics and have a conversation about them and really look at who they were for. I mean, in essence, if you're going to collect information about skill mix, who uses that information? How is a consumer supposed to use how many LPNs there were, or whatever. So we had some interesting conversations because, of course, from a nursing perspective, they think everybody should think all this stuff is really important. But I couldn't figure out how to translate it most of the time into a consumer-oriented piece of information that they could use. If you go out and look at a hospital, we'll show you as we go through it so you can verify for me, as a lot of consumers, what you think this means and how you might use it. But it was a useful conversation because it actually guided some of the changes that we did make in the narrative. Because that's what we realized we could do in the first phase, was go through and let's just clean up the language, look again to see whether we had language that was geared at the reading level that it should be for public information. Was it clear as it should be? What, that type of thing. And really was more inclusive of the nurse-sensitive measures because the old page actually didn't even refer to the fact that nurse-sensitive measures had been included. You had to know where to go to find that. So we made some corrections in that space. So the second phase we'll talk about as we kind of move forward here, I think, but that first phase was, I think, very useful for us to get on the same page again about what we're collecting and why, and then what changes that we could make. So we did work through making those changes. I think that unless you've got some questions right now, it might be worth just looking at the report card, and then that might drive more questions even from.
That'd be terrific.
But I want to make sure that we keep this open if you've got anything. So this is CHA's main page. If you go to our main page and you go to Colorado Hospitals and then down and over to the report card.
I'm sorry, 100 hospitals is what percent of the total hospitals in Colorado? Did you say you had 100 members?
Yes, but
Okay.
I actually couldn't tell you that today because I don't really know the total number of hospital licenses.
Is it half or most or?
It's most.
Oh.
It's like
Most.
98%.
Okay,
Okay,
thanks.
It's a very close.
Some
Perfect.
of those hundreds are big groups that have 10 hospitals.
Got it. Thank you.
So you go to the hospital report card page here, and this page in the past didn't really say anything about nurse-sensitive measures at all, but realized thinking about it from a consumer's perspective, we thought we needed to talk about the report card and then talk about nurse-sensitive measures and give people information. If you wanted to just go see what the select health measures were, you could click on that, or you could go click on the nurse-sensitive quality measures and just know what they were and just get a brief summary of what was being collected. you could go straight to the report card if you wanted to by clicking on that particular box, but you could also, if you just want to know what the measures were, look for it. So then we went into this particular page and made several changes, actually. So we completely changed this welcome to the Colorado Hospital report card box and added a whole paragraph about the nurse sensitive metrics and measures. Realized that there's this interesting thing about, you call them metrics, measures, indicators, so there's a bunch of different ways to talk about it, but the statute says measures, but the NDNQI speaks to indicators, so anyway, so know that we tried to stay sensitive to the language in the statute throughout the whole thing, if we could.
And I'm going to pull up just a sample one. I will show you. I'm going to pull up a sample one. I looked ahead so that I would find one where you could actually see a trend. So, and this is way beyond my usual focal distance. So sorry about that.
Did you go to Parkview?
Actually, I went to St. Mary's.
Oh, the list you gave me is Parkview. Okay.
Oh, I'm sorry.
No,
All
that's
right.
okay.
Okay.
That's okay. So this particular, let me back up a little.
And talk about.
Can you go back to the page I was on, just for me to, again, not that one. There you go. So if you look on the left-hand side of the page, those are the metrics that are being collected on the hospital report card. Those are direct links to those measures, and you can go in and look at what they say and how you do it and how to read them and how to interpret them, et cetera. And you can see some comparative reports across hospitals. When we added the nurse sensitive measures to the report card, we did not do it the same way. The way we did it was by creating a hospital specific report that we're now calling the Colorado Quality Report. By that language didn't look right, but anyway, the quality report by hospital. So now what you get is a report. You can choose which hospital, you can choose a year, and you get the hospital report card data first, followed by the nurse sensitive measures. So the nurse sensitive measures are only being collected on hospitals with 100 beds or more. So you won't find nurse sensitive measures for Haxton, but you are going to find them, for NCMC. For the nurse sensitive or for the report card? For the nurse sensitive? Well, I think there had been a hope or intent when the legislation passed that the NDNQI would provide some of the benchmarking for these metrics that you could go against. I don't think anybody necessarily anticipated that. So maybe you can give the background on NDNQI, correct me if I've got it wrong. But that started with the American Association of Nurses, and the University of Kansas School of Nursing created the first database and managed it. Somewhere along the line, Press Ganey bought it. And that's what introduced the proprietary nature to it and precluded us from using or getting access to the data. Well, I agree. I think that in that phase two, I think that's still something that we can take a look at as we move forward. I have made attempts to contact them to try to figure out a way to try to do that type of work. What we also discussed was the majority of these measures were created with the idea of hospital leadership using them. So that inside a hospital, it gave you information about, we hoped that you were using the information to make decisions about the staffing that was needed in your unit, or any given point in time, or what you needed to do to help the nurses be more involved.
Yeah,
so
I see that at Denver Health,
right.
Director, and you go through the data.
Right. So you do it yourself.
Yeah, we kind of, we also have we get benchmarks. So.
Yeah. There are standards, I would call them standards, recommended minimums. Benchmark is a word from my experience that has been introduced for staffing specifically from consulting companies that come in to try to re-engineer staffing matrix. So those aren't really benchmarks, although they use that term, but they often vary widely from standards.
That potentially obviously help you in terms of your staffing ratio.
And that was actually, right, I think that was the intended goal, is that it would actually encourage hospital administrations and leaders and nursing leaders to actually use the information and discussion. So I'm really pleased to know Kathy's bringing it forward too, that you would know about it as well. But knowing Kathy, I can imagine she likes to talk about it. She's not shy.
Can I do a quick time check with the three of you, please, just to make sure that we're tracking with about how much more presentation might you have?
As much as you want, okay? But I think that's the point. I just wanted you to at least see what's here and see if you had any questions. Know that where it says view definitions on the top of that box, you can go in and find more information. Again, back to what is included in this score and what does it mean. So I guess know that you can find out more about it as you want to, as you move forward. I think so we've done our first, this first phase of changes to this to try to make improvements to the website. What I think is none of this addresses is really like the analysis or the analytics. So we never did, if nothing else, we didn't have an analytics team at the time. And I think we had one nurse working for us at the time. We certainly have more now. But in essence, we didn't really have the in-house capacity to do the kind of analytics that would be required to figure out how to use it in a bigger space. However, it was supposed to be available if any researcher wanted to use it. I couldn't find that anybody had ever requested the data in order to do any work with it. So the opportunity is there to do more with this as we move forward. However, I will say that House Bill 1001 passed and is on the governor's desk. And in that's a hospital transparency bill with a lot of new reporting hospitals are going to be doing to the Department of Healthcare Policy and Finance. And one of the last things in the bill is that Healthcare Policy and Finance, CDPHE, and the Division of Insurance by November 1st of 2019 will review the hospital report card and see and evaluate its effectiveness and value. So there's phase 2 out of my hands kind of thing. So
that's good news, though. Yep.
Yeah, we'll see what happens out of that as it moves forward. I think because there's already also going to be required staffing and information to be reported to HCPF as well in that transparency bill. So there will be even more information available at HCPF to look at a variety of things associated with nursing. I think the only other thing I had thought about talking about, and it really is up to whether you're interested, is that whole issue of the specialty nursing and workforce shortage in nursing, if you're interested. Otherwise,
I think we're all pretty aware of what an epidemic it is and remains, the workforce shortage in nursing today. Is it fair to call it that? Maybe this isn't the right place to say the word epidemic, but
you got to watch that.
That's right.
I'm on the governor's emergency epidemiology.
She's on the GERC, yes.
Are you on the GERC? Isn't that a fun name? Right, Dan? Isn't
Expert
that a fun name?
emergency.
Yes.
I always forget how many
Nice.
Well, I found this very helpful. Ms. Hammond, did you have
I almost think that could be a whole nother report another day. It's
You bet.
I do too, because I think there's a difference between an RN shortage and a specialty nurse shortage.
CNA.
Okay? We got lots of new RNs, but they can't go to work right away in an ICU.
Check.
And so it's how do we get them from being a new RN to being capable to work by themselves in a critical care unit or an OR or an ED. So those are some of the issues.
And what can we do to retain them?
Yeah.
I will say Press Ganey has also purchased the NDNQI. They just more recently purchased the California Nursing Outcomes Coalition, which was really the precursor to the NDNQI going back into the 70s even. And they've begun to publish their analysis. And so they have two Sentinel reports that just came out late 2018 on workforce retention and recruitment related to their data. So I think they're making progress with their purchase of the product and analysis of the data.
And that is NDNQI. I heard Indian QI the whole time.
Press Ganey is the new, so Press Ganey does consumer satisfaction surveys for a large majority of hospitals, so patient satisfaction. And now they've added this nursing workforce database to their complement of services. And so you can be a part of that and then analyze it and get consulting. You can do get benchmarks.
Benchmarks. There's benchmarks. Great. Excellent. Ms. Hammond.
I think if we did a future report on workforce and shortages, I'd love to see you add the information about CNAs as well, because the lack of those just makes the job for the nurses even harder, and then you lose the nurses. So if we could combine that, it'd be great. Thanks.
Thank you all very much for being here today. We really appreciate the information. Everybody good? Any other questions?
I think you need to let it absorb.
Okay.
If they have questions for me, I will follow up with you, and that way we can go from there.
Thank you.
Thanks for your time.
Thanks so much.
Oh, thank you, ma'am.
Mara, good afternoon. Hello. Come on up. Mara, this is Mr. Butts. Mr. Butts is our newest board member. Mara is our legislative liaison at the department. Is that right? And I call her Mara instead of Miss because I believed I pronounced it weed whacker the last time that you were here. So I'm just going to call you Mara if that's okay.
Again, I want to be like Cher someday and just
Okay,
Mara.
just Mara. That's fantastic.
It'll all work out well for everybody.
Terrific. Well, I know that you're always pressed for time.
I am.
Having to head back to the Capitol. So go ahead, please.
First and foremost, thank you so much, Board of Health, for having me here today. It has been an incredibly busy legislative session so far, especially in the healthcare realm. I know that we've been following a lot of bills, including the medical marijuana for autism bill and medical marijuana for opioids, and I'm happy to give a quick update on that. A few of the other healthcare bills that have been happening, there's been the rural-based cost for hospitals bill that is going through currently right now. As well as freestanding EDs, which our department has been very active in from a health facility standpoint. We also had the maternal mortality review committee. I can never say that correctly, which went through quite well. We're glad to have funding still for that within CDPHE. I'm happy to answer any questions if there's any bills that are pressing currently, because I know that that might be easier in this current climate of quite a few different health bills that have been going on, as opposed to me talking about each one of them in depth.
I've heard from some friends that there are some things going on at the Capitol that folks have never seen in their lifetime. Is that fair and accurate?
That is. A quick snapshot of that would be last Tuesday, the Republican caucus asked for the Title 12 bill, which needs to be passed every year to be read at length. It's a 2,023-page bill. It was a long and not productive day. The majority at that point in time decided to have the bill read via computer and on something to the effect of 6 times the speed. It was ruled in court this morning that that was illegal. So there will be no more court readings or computer readings, excuse me, of bills, which should make
multiple laptops at this.
Right? Yeah. It should make the long bill next week really fun. Looking forward to it.
Great. Well, thank you. Anything else to report before we ask for questions?
Currently, no. Happy to answer any questions.
Thank you. Questions from Mara? Mr. Butts?
This may be from Mara, maybe from Deb. Is there normally like a legislative session wrap up presented at some point, or is that?
So in the past, we have done that, but Mara is, thank you. Mara is new, and so we'll figure out maybe if you want to do it as a report out or if it's going to be like a one-pager that we do with staff, just so that they can track. I also then track it for just zoning in on what you all need to implement because we're creating space in the rest of your calendar. So there's sort of 2 tiers of action, your daily business being affected and then like the scheme and how it ties to the strategic plan and all of those other great things.
One of my goals as the ledge liaison here is to be incredibly transparent about what's happening down at the Capitol. And so I would like to give a report or a 1-pager at the end of session. I ask that it not be in May and you give me until June to come up with that report would be very helpful on my end. But I do think that that would be most appropriate.
Okay, I had just noticed a number of bills around Board of Health in certain areas, and
You guys are going to have a busy fall.
Some update on those things coming and going.
To that note, do you want to speak to, there we go. On that note, do you want to speak to the fact that we had a slate of statutory cleanup bills involving the board that you really don't necessarily need to take any brain damage on?
Correct. I'd be happy to speak to that. We had 11, we called them obsolete bills in the department. That was really cleanup language from the Statutory Review Committee. We had originally hoped that they were all going to go through as one pretty little package. The committee decided against that and to run each one individually, which made for my first 2 weeks at the Capitol interesting. They've all passed through without issue whatsoever. Both chambers, they're getting voted on. We really appreciate the Statutory Review Committee for taking the time and finding sponsors for each of those bills. We have not had an issue with any one of them, and I think 10 out of the 12 have officially passed both chambers, and we're waiting on the last 2. But again, don't anticipate a problem, but we're seeing quite a few bills being read across the desk right now, and that's one of the many. So,
thank you for the question. Anything else from the board, Ms. Hammond?
A request that's a little strange because it's the veteran state nursing homes come under the Department of Human Services.
Yes.
And so this is a little out of our realm, but it has to do with nursing care. There is a line item in the budget that wasn't a bill, but it was just a request in the budget because these people who work there come under the state salary ranges. And they're all being paid like $2.50 less an hour than private nursing homes.
Okay.
And so it's gotten to the point where the staffing is so low, they're not accepting patients. And eventually we could have to close the state veteran nursing homes. So last year, this item in the budget got right to the last meeting and then it got axed.
Okay.
So if there's any way you could sort of track that for us.
Happy to.
It's crucial for hundreds and hundreds of wonderful veterans in our state.
And I'm just writing this down as a note. It's the state
nursing homes.
Got it.
Part of the CDHS funding
budget.
JBC as they're doing take backs and things like that.
I will connect with the DHS ledge liaison and make sure that we're tracking it together.
I appreciate that. I know it's a little out of the realm, but it's all about nursing. So thank you.
Happy to do that. Any other requests as we head into budget season?
Breathing. Good luck.
Appreciate it.
Self-care. We would advocate for self-care, Mara. Thank you very much for being here.
Thank you. Take care.
All right. We've heard from the AG's office and board members on committees. Do you have any reports that you'd like to give today from the GIERC or Ray? Do you have anything?
Yeah, for our Tobacco Review Committee, briefly, last month's meeting really focused on the further a discussion on the funding reductions for the last 2 years of the Tobacco Review Committee grant. We had asked CalPO to look at our portfolio and give recommendations or opinions on some of the cuts that we made because there were some major cuts. And then they gave the presentation followed by a very, very lively discussion with grantees and ex-grantees regarding the funding cuts, and discussion really focused on priorities of the allocations, and whether, because a big chunk of it was the quit line versus cutting programs that have people associated with it. So there's a lively discussion. Everybody's still talking to each other at the end of the meeting, but it had some strong opinions and within the committee itself. So because there was questions in terms of what priorities we put on certain programs. The biggest target was the quit line because it has the lion's share of the funding, which I think, in my opinion, is one of the more evidence-based interventions that we really have. And a lot of the programs, really, their focus is drive people to the front line. And so that's it.
Thank you.
People are on the committee. Wow, okay. Good luck.
Oh, yeah.
That's Pat volunteering to be your successor. That's what
Yes, I'm making a mental note.
Dan, did you have an update?
Yeah, there had been no GERC meeting since the last meeting, and as far as I know, I haven't heard of any new epidemics. I generally hear of them. So other than I'm aware the Hep A issue is stable and has not taken off, and we're coming out of flu season, so that's always exciting. So no big epidemics in Colorado as far as I know.
For workforce shortages.
Ice facilities. I
say that out
loud.
Oh, you're right.
Yeah.
Yeah.
But it's not, unfortunately, really under our
Purview? No? Questions for Dan about that? Sean, did you have an update?
Not a huge update. We've been focusing on grantee presentations for the most part. We did have a brief I'm on the Cancer Cardiovascular Pulmonary Disease Review Committee. Yes, CCPD. We did have we had a presentation about kind of the trend in the budget and what that's going to do. We did not have lively discussions yet because when we made our cuts back in, when was that? September, October. We tried to be cognizant that the funding could continue to decrease, so we kind of overcompensated a little bit. My guess is we'll probably have some continued discussions. Something tells me our chair is leaving in June, so he's waiting until after he's gone to kind of put that on the agenda and leave that up to the rest of us. So we'll see how that goes. But hopefully...
Not me. He's not talking about me.
No. I'm talking about the chair of the CCPD.
See, no, he just volunteered to be your successor.
Yeah. Please, no.
I love that. That's a great idea.
So yeah, that's what we've been doing. I think you'll see them in June. We've got a couple vacancies that we have to fill, so there'll be some presentations then. But
great,
that's all we've got.
Yeah, would you give my update on where I'm going to be from 2 to 3:30 today to the
Yeah,
board,
I can
so
do
that I
that.
don't say the wrong thing?
Yes. Do you want me to start with that?
Oh, that'd be super. Any other updates before I turn it over to Deb?
Okay.
Okay, thanks, Deb.
So from 2 to 3 today, Matt will be at the preventive block grant discussion. So board members might remember that this is the one time on your roster where you move into an advisory capacity. The block grant requires that we hold a public hearing. In the past, the board has been willing to sort of serve in that capacity and hold it as part of your meeting day. And to do that in a way that makes sense, we ask a member to sort of serve on the internal advisory committee so that there's a nexus so that Matt can be informed before they come to the table. That said, that funding and the grant are a bit quirky, and so we are really studying, and some of it's being driven by practicalities. So you have a very full April agenda. I'm trying to cancel May so you can go to the symposium. June is Pueblo, and we have a grant submission deadline. So little things like, is this the right forum, and how do they hold a public hearing that's not in this forum? So we're working through all of that. Some of that will be the discussion today, and Matt will be able to go, yeah, we've done these. We usually have 30 staff in here for about 20 minutes while you guys ask questions. Is that really the most effective way to be doing it? We're really making an effort under Jill and Mike's leadership to tie that work to our strategic priorities. That's also in the queue. I'm a member of our strategic planning committee so that I can see those nexuses and have those moving parts in place for you all while we're working through it. But we are really going to not have that plan. I mean, it's not even going to be submitted until June, but I would say it's not going to be baked until the end of April, and then we're going to do some more vetting of it. So that's where Matt will be from 2 to 3.
Thank you.
Okay.
Yes, thanks. Ma'am, would you like to do that instead? No? Okay, I'll do it.
She's like, are you really talking to me? Why not?
Anyone in the crowd? No? All right. Nope, sounds very exciting.
So just, I have a laundry list of things, so I'm just going to go through them as painlessly as I possibly can. In terms of the public comment received from Dr. Finn, I just wanted everyone to know that Dr. Finn is well known to the department. We've worked with him regularly over the years. I did confirm with him that he was in fact trying to communicate with you all because some of his comments were directed to the Sunset Review, which was happening a week after I got the submission. So we made sure that he was covered there. Most of his concerns are with the medical practice, and it's for the medical board. So I just wanted to let you know that staff have responded to that. Along with that, I'll be responding to a constituent. I'm happy to send it out to you for next month, but I received it yesterday, and she basically was looking for public health effects with regard to internet service in rural communities. I don't think we have a lot of research on that, and I'll probably be referring her to the State Internet Portal Authority because they would have more information about that. She was a big fan of wanting to make sure we improve wireless coverage in our rural communities, and she was just trying to look for some resources. So nothing there other than the fact they didn't like the idea of it not being posted for a whole month. So just know we're on it. We're working through it.
Deb, just so you know, that's a huge issue in rural communities.
It sure is. It sure is. I'm well aware. And when Lou was here, he certainly spoke to it a lot. So yeah, point taken.
Nothing else in contacting people when there's emergencies and issues.
Yeah. I did the 2013 fires for child welfare kiddos placed in all of our rural communities. And so, yeah, I really do understand what you're saying. Yeah. All right. So thank you for everyone that has RSVP'd for May 9th. We have a very good turnout, so thank you very much for that. I did want to make sure folks knew that both Pat and Matt can't make it, so you will be representing the board in all of your capacity, which you're already going to do. Ron, if you can let me know if you're going to make it. Do you think you're going to make it? Okay, awesome. So yes, that'll be great. So we're working out all the logistics about where to sit and all of that good stuff. You can about imagine where, it's little people and who's beside whom and all that great stuff. So we'll get it there.
It's like weddings.
It totally is. I really do kind of geek out on it. It's sad. All right. I don't know if board members had a chance to take a look at it. And Tom, thank you, because I had 2 of one attachment and not that attachment. But do folks have feedback on the Board of Health history for debilitating conditions? It was a 1-pager. If you have feedback for me, you can let me know. I'm happy to post it up on your website. So the Board of Health has the website for the petition process. So I thought about just including it as a link so it's just publicly available. So, okay. Yeah.
Thank you.
Happy to. So I will get that posted. If you do end up having any feedback, because I appreciate that I think I only sent it out yesterday. Was it yes? Maybe Monday. Okay. Then just get to me within the next couple of days. Yeah. So just get to me and then I'll work on getting that done next week. I have a recommendation into the governor's office to fill our last vacancy for Congressional District 4. So I'm hopeful that they will be here in time for our next meeting. So for me, this is very exciting. Great pool. It was a real, even though it was very hard this time around, we still have great quality out there and it was fantastic. So that's coming. Amy's replacement should also be back for us in April. So I'm just needing to work through the last few steps of the process there. And so they will be starting. And then folks have been asking me about confirmation hearings. So if we get our CD4 seat filled, 6 of you will be up for confirmation hearings sometime here in the next 6 weeks. I have no more information beyond that. So the reappointments plus the new guys plus my midterm vacancies.
Wow.
I know, we're going to have a great time. But you remember, we all kind of came in as a crew the last time too, and it was a delight. So I think it'll be fine. I will let you know.
We all know who's not part of the 6?
So you're not part of the 6, which was a funny story, but we won't go in. So I don't believe Pat or Sean are part of the 6. So yeah.
That's high-fiveable.
Yeah, totally. So
Not that it's awful. Sorry, not that it's awful.
For folks who haven't been through this before, Ledge Council will send me some dates and then I will be sending it out. Love it if we could get you all in as one group. That may not be possible. Ray had the joy of doing it literally on the last day of the session the first time we went. It was fantastic. They barely had human beings in there to confirm him, but it got done. So it'll be fine. Totally.
She was there or wasn't?
She wasn't.
Yeah, because it was the last day, everything's off. Yeah. And then the last piece, and Sean, I hope it's okay if I mention this, but we're canceling our May Board of Health meeting. However, if you happen to be in town or if you still have that time blocked on your calendar, Sean Turk will actually be giving a presentation to our staff with regard to his transition and LGBT issues. And so we're also trying to arrange call-in and listen in and YouTube access. So you'd be able to do it remotely. So if there's anyone that's interested, we have that invitation available to you. And just a thank you to Sean. I know that we had some folks in our LGBT employee resource group, and when they learned about Sean and that Sean was on the board and in a position of authority, it was a very affirming moment for our staff. And so just really appreciate that he's willing to sort of carry that torch a little longer for us. So thank you.
Good job, Sean. That's fantastic.
So it'll be your third Wednesday. So they're literally taking this room. So instead of having Board of Health, we're going to have not day of Sean, but probably a half day of Sean. So see, when you say it, my December birthday boys got their cake. I will meet your needs. We don't have a time scheduled yet. I will let you know when there are more details. I just wanted to let folks know. And I think that's all I had. Do folks have any questions for me? So Pueblo is in June. That is still on. We are very much trying to do sort of a 10 to 3 for those of you that need to keep it a single day travel. If you already know that you need a hotel the night of or the night after, please let me know. I'm happy to make those arrangements. We have, I think, 3 local governments that are coming in to present on their local plans and priorities. We're arranging, because the strategic plan should be fully out there at that point, for Heather Weir to come and give a presentation about the strategic plan as well, so that they can hear it while we're down there, and it should be really good. The other piece for long-term planning, it's still here in the Denver metro area, but Matt has graciously agreed to host our August Board of Health meeting, and we'll be flipping things around a little bit there. We'll be learning about the community center board world and what the provider community looks like, as well as hearing from families and advocates of individuals with intellectual and developmental disabilities. We're actually flipping this so that we're sort of in the position of being taught rather than leading anything. And we've invited some key staff from our department. And then thank you to Jill. We'll also be inviting the executive director and staff, as well as the boards from HICPUF and CDHS.
Yay. That's the best news I got today.
And they're awesome.
That's fantastic.
Great partners.
That's great news. Good. Thank you, Dad. Oh, that makes me so happy. That's wonderful.
Good.
Sean, I'm going to be in Portland. That's why I'm missing the, what'd you call it? A consortium symposium
Symposium.
thingy? That thing. So I don't think I'll be able to participate, but that's really great that you're doing that. I can't wait to hear. I'm sure it'll go really, really well.
No pressure. It's like the first one. Isn't it? It's like,
no pressure.
It's a little bit of a lunch.
But you're getting a cake.
You're a pro.
Yeah.
All right. Now everybody's going to get a cake. I felt special for a second, but that's fine.
Just for a second, and then we move on.
Okay, so I wanted to mention just something very quickly to the team. I hope it was okay when I asked Miss Finley and her friends about a time check. I whispered to Deb and said, so what's how much time do you give them? And while the information was super interesting, my guess was Miss Finley would have kept us here till about 5:30, because she's really, really excited and invested in the information that she was presenting. I'm a real firm believer that we have all got day jobs to do, and we have all got things to work on. And if we're tracking an hour early on our agenda, I'm going to try and get everybody out an hour early. Just because I think it values everybody's time here. And I think in the past, sometimes we've said, okay, well, if we can be here till 2, we're just going to let folks go, and we're going to bring new stuff in, and just we'll be here till 2. And I'd like to take the position that if we can save the time and get us all back doing our regular duties, then all the better. Is everybody okay with that?
I second.
Yeah.
Okay, great.
Can we give them time limits too?
So time limits were in fact provided. I do think that we do not regularly have external presenters for a variety of reasons. So to your point, Pat, about looking for that workforce presentation, I'd really like to see how far health facilities can take it. They know your tempo. They have a pulse on the issues so that we can really have department led. But I really appreciate how much CHA has done on this work and really wanting you to hear that history. So I appreciate that you took the time today to hear it. It's a very kooky statute because they basically volunteer to do all of that work. And then it's only when things get bad enough does the statute trigger for the department to take over. So just really wanting to appreciate that. So point taken. I will keep the externals to a minimum for that very reason, but I also think that we can work through.
Yeah, and I'm not trying to say a minimum, but if we say it's 20 or 30 minutes, then as the chair, I'll try and say, okay, so we're tracking about 1 o'clock. Right, well, I'll do a check-in and then I'll just try and keep it moving a little bit, just for everybody involved.
And there was no big hurry on my request on the workforce report. I was trying to cut things down and thought that maybe that would make another report another day. That's all.
Yes, no, I got that.
Okay.
Was there something up here that you wanted to point out? Or?
Oh, I'm not going to do it today. I don't think that today's the best day for it, but just in terms of still keep thinking about the health equity conversation that we had last month. I actually had all of this going, but then we had our strategic planning prep meeting on Monday, and I know that we're going to be doing more work on this health equity piece as we do that. So I kind of want to see how that starts to cook and see where the board could plug in effectively. So I'd like to pause if that's okay.
By all means.
But I don't want to see it get too far from the conversation we had last time because that's all fresh in our minds still. And so.
Okay, point taken. I'm happy to see if I can still block out some time in your April agenda. I know we have a lot going, but I think that that's a real possibility. And I definitely have work session time that's not part of your board meeting that I've slated for July where we could head upstairs to have a conversation. So we could sort of have brains percolating conversation in April. June, you'll hear about the strategic plan, and then you'll sort of be able to say, how do our ideas test to compare to that? And then in July, we can do some really good cooking, and Webb's team is coming back in July to be part of that conversation. Then you'll have the joint meeting in October where we're going to revisit health equity with the Air Quality Control Commission.
Sounds perfect. Thank you.
Any other board business today from anyone? All right. Any objections to adjournment?
Sounds good.
Seeing none, we are adjourned. Thank you all very much. My pleasure. Would that be okay? Please. I actually got out of it 3 o'clock. Oh, I mean, yes. Let's just leave it to.
You're going to be fine. I need to take this. Do you mind? Oh, yeah, that would be great. Thank you. Then I can stay and get all this.
You want me to stay and help?
I'm good, but I appreciate the offer. Thank
I thought that meeting was going to go on and on. Oh my gosh. And she said, why? One more time. Is this a report about you or? Yeah. I thought you handled that really well. I was ready to ask her whether it was a report on that we I think they mentioned herself like
And you know, I found that used to be on this board, right as I came to choose.
oh, the radiation.